for joining us today in our conversations. We are going to do some introductions because I am conscious that there are some members that have joined us today that might not know who people are. So quite useful to do a quick round robin of introductions. In terms of housekeeping, there are no planned fire alarms that I'm aware of, if somebody tells me different.
There aren't any.
But if we do hear one, then we are leaving through that door and convening in the car park. And I think most people here will be familiar about where the facilities are if you need to use them. Tea, coffees in the corner. Please do help yourself as the meeting progresses. So in terms of introductions, let me start and I'll go to my left to Adrian. I'm Wendy Lauder. I'm the Place Director for Barnsley. I'm also the Director of Adult Social Care in Barnsley.
I think you all know me. I'm Adrian England. I'm Chair of Health Watch Barnsley and also Chair of the Mental Health Learning Disability in Nordic and Berkshire.
I'm Jill Stansfield. I'm Clinical Services Director in South West Yorkshire Foundation Trust, and I'm responsible for community services. Good afternoon, everybody. I'm Jane Sivakumar. I'm the Chief Nurse for Barnsley.
I'm Richard Jenkins, Chief Executive of Barnsley Hospital and Reserve.
Kevin Clifford, I'm one of the non-exec directors of Barnsley Hospital across the road, and I'm here today for Gina, Chair, who's away.
Welcome, Kevin.
James Barker, I'm the Chief Executive of Barnsley Healthcare Federation.
I'm Makinson. I'm covering for Steve Alton from Barnsley as Deputy. I'm the Deputy Leader of Barnsley Council.
And congratulations. Yeah, really pleased about that, thank you.
Hello, I'm Michelle Kay. I'm a Group Leader for the Housing and Welfare team at Barnsley Council, and I'm coming to present today.
Thank you, Michelle, for taking the time out today. It's very much appreciated.
I'm Roxanna Naylor, Chief Finance Officer for Barnsley within the ICB.
Hello, my name is Martine Tune. I'm the Chief Executive and Chief Nurse of Barnsley Hospice.
We'll keep them around the table and then onto the screen, Bob.
Okay, Bob Curtin, Deputy Chief Executive at Barnsley Hospital.
Hi, I'm Kirsty Blacknell, Head of Communications, Engagement and Equality at NHS South Yorkshire.
Paige Proud, Risk and Governance Lead for Barnsley Place.
Kay Morgan, Governance and Assurance Manager.
Thank you, Jane.
Hi, I'm Jane Holliday. I'm the CEO at Barnsley CVS.
Thank you, Leslie.
Hi everybody, apologies I'm not there in person today. I'm Leslie DeBell. I'm non-executive member on the South Yorkshire ICB with special interest in Barnsley.
Thank you. And last but, oh no, not last, Salma.
Salma Yasmin, Director of Strategy and Change and Deputy Chief Exec at Swift for at least the next 5 weeks.
Falling on to that before the new role starts. Richard?
Yeah, hi everybody. I'm Richard Walker. I'm the Head of Governance and Assurance for the ICB.
Thank you. Jamie?
Hi everyone. Jamie White, I'm the Deputy Place Director in Barnsley for the ICB.
And Madway, as you're trying to find a chair. That was helpful. People do look different on screens, don't they? We used to see them on the team set. So yeah, that's really helpful. Apologies, Kate.
Apologies from Mark Brooks, Julia Burrows, Houghton, Sheena McDonnell, and Sarah Norman.
Thank you very much. We are quorate.
We are.
Thank you. We're quorate today. Item 4, any declarations of interest relevant to the agenda today? Anybody wants to share? No? Read Leslie.
Yeah, just to note, please, that I'm now retired as Chief Executive at Age UK Rotherham as of the 28th of February this year.
Thank you. Thank you, Leslie. If we can update the records appropriately, please, Kate. Thank you. So without any further ado, Michelle, it's over to yourself. Thank you.
Sorry, Wendy, just to note that I'm here for Mark Brooks.
All right.
Well.
Thank you, Sally.
Yeah, thank you.
Thank you. Right, it's over to you. What, Michelle?
So, hi everyone. As I said, I'm Michelle Kane. I operationally manage the homeless service at Barnsley Council, and I was asked to come today to talk about how homelessness links in with the health agenda and the housing agenda generally, and it is pretty critical for me that health, housing, homelessness is all working together in a kind of whole systems way. I think I've got some examples today of where it doesn't always connect, and there's work that we can all be doing together to kind of make it connect a bit better. So in terms of what we do, obviously we manage the statutory part of homelessness, but what's become very what's focused my mind for the last year is we've, in COVID, we had to get all our rough sleepers off the streets. Government told us as a result of the COVID pandemic, get the rough sleepers off the streets, which we did. We stepped up some flats. And as a result of that, it became very clear to me. I mean, I've worked in housing for 27 years. I've worked with some of these clients for probably 20 years. I know them personally, I know them really well, some of them, unfortunately. And it is an area I'm very passionate about, homelessness and housing. And we got them all off the streets. And I went to Wendy at the time and my senior managers in council and said, we need to manage our own accommodation, this client group. They're going to end up back on the streets. We're going to be back to square one. We need to try and manage it. We have got some commission services, don't get me wrong, they're really good. But when you're a commission service, your target's sometimes different and it's sometimes easier to kick somebody out. I'm not saying we don't kick people out, because we do sometimes after. So we put a business case forward to open a residential unit to use as temporary accommodation for the most complex rough sleepers in Barnsley. That opened last July. So we've been managing it for just short of a year, and it has become very clear to me about, I think I always knew it anecdotally, but I think I've got a lot more evidence now about some of the gaps in service, how we need to work better together as a system to support this cohort. So the majority of people, we've got 13 units up there. We take couples and singles over 18. Like I said, they've all got very complex needs. Some of the common health needs that they have are things like, a lot of them have got DVTs, a lot of them have got a lot of wounds from injecting that are always infected and need dressing. Quite a lot have got respiratory illnesses from being on streets a long time, COPD, kidneys, liver, epileptic. They don't engage very well in health services, I think it's fair to say. They don't access them very well. Mental health is a massive issue for this client group. The majority of people, well, all the people that I work with up there have suffered trauma, at some significant trauma at some point in their life, and never address that trauma really, or never know how to deal with that trauma. Substance misuse and drugs and alcohol is a massive factor in all the clients that we manage, as is offending, repeat homelessness. So I kind of wanted to talk about some of the stories that we've got up there, some of the cases, what we're doing with them. So we've currently got quite a complex couple that live with us up there. They've been with us 6 months. Prior to that, they were both rough sleeping on the streets, probably on and off for a couple of years. We obviously treat, they are a couple, but we look at them as individuals because they've got very individual needs. He's been a drinker for many, many years, and probably the last 12 months while he's been on the streets, took a lot more drugs than he's ever took, injected quite a lot. So he's got really bad wounds to his legs, really bad. Not right good at getting them dressed, not right good at looking after his personal hygiene generally. He's also got COPD, he's epileptic, he's diabetic. He doesn't really engage in services for that. We are trying really hard. We managed to get him back with his GP and things like that. They don't tend to go for the general health checks anyway, you know, the screening and everything like that. But we are trying with him. He's started to have his legs dressed. So we do have the health integration team do come on site, which is really positive, once a week, and they will try and get them to have the legs dressed, and we'll try and support them to do that.
That's going to be by, is that Swift?
That's it, yeah, the one at, they're great, they're brilliant, but they can't do it forever. They need to get them into mainstream. So they need tissue viability nurses. They need to go to, we make appointments for them, but they don't go. We try and take them, they won't go. She's got very similar issues. She's in Barnsley Hospital, I would say, over this last month. I bet she's been in Barnsley Hospital 5 or 6 times. Most recently last week. She's a big drinker, big drug user, massive mental health problems. She got asked to leave the hospital by the consultant because he was taking alcohol in for her, and she got alcohol under her. Yeah. So we're evicted, but then we had her back on site. She tried to overdose them. We're called an ambulance, and you know, we're going to all the debates about capacity and should she be took to hospital. So we felt we were kind of left on site thinking, well, how do we manage her now? because she refused to go when ambulance came. And it's just a repeat cycle all the time with them, despite us, you know, looking at their best interests and telling them and trying to work with them. There is domestic abuse between them as well, because she blamed him for getting kicked out of hospital because he took the alcohol in, and then when he came back, they had quite a severe fight and he tried to strangle her. So there's like domestic abuse between them. So these are the kind of people that we're kind of dealing with every day, and it's not easy, but I just think we need to think about how we support. We're housing specialists. Ultimately, that's our job. They're housed, and we can get them housed. What we're not is mental health and drug specialists and health specialists. Really, it's trying to work with you lot collectively to get them other services involved, and it is really difficult because I know we're all under pressure. I know resources are really tight, but you know, they'll go to one appointment, then they'll miss the next one, so they're kicked off, and then we're starting again. Same with drug services. If they're on script and they miss one, we have to start again and get them retitrated and things like that. So it's them kind. So we've got them two, and then the other one is more a mental health one. It's quite a sad case, really. He's only 21. He grew up in care. He's had a not very good life, really, so far. So he's only 21. Does take a lot of drugs, but really, really suffers in terms of self-neglect, self-harm, don't look after himself. You know, he's really traumatized young man, really, and uses drugs to help him get through that. But last week he's been in and out of mental health services, but keeps getting kicked out, in and out of section 136 because he's found on bridge, or he's found, you know, last week he tried to hang himself up at Queen's House, and he's now sectioned again. But the last time he was sectioned and came out, he really needed that package of support around him, and he was discharged without it, and he did it again. And I'm worried that it's going to happen again. He's going to come out and he's not going to have that package of support around him, and then we'll kind of be left thinking, how do we support him? It's not that we don't want to, we just don't know how to, really, to some extent. So they're the kind of case, but don't get me wrong, we do have success. We have got quite a lot of cases up there where if they will engage, I think a lot of it just takes time to build them relationships, to get to know them, you know, speak to. I mean, I turned up on site this morning, one of the fellas I've known, but I've known him about 15 years. He's been on streets 15 years. And he keeps saying to me, I'm going to die on streets. I'm trying to say, yeah, but you need to sort your health out. You need to, and he knows that his heart's failing and his kidneys are failing. But like when I turned up this morning, he said, you want to kind of tell him, Michelle? No, not yet, it's a bit early. But he'll go when he's not ate for a week, you know, and I'm like, you need to eat, but I've got no food because I've spent it all on alcohol. And it is that constant, but they need to trust us, really. It's building that trust that takes time and stuff. We do have drug services on site, but again, due to resources, they can only come once a week. It's not enough for them, you know, in terms of trying to get them to, because I'm under no illusion a lot of these are not going to stop taking drugs and drink, but what we need to do is it's that harm minimisation and make sure that they're doing it a bit more sensibly and things like that, because they harm themselves as well. So it's that kind of story. I think the learning for us that's come out of it is that, you know, engagement with services is very sporadic. It is on their terms. I must say they're very difficult at engaging in primary care. We have managed to get every single one of them, touch wood, now registered with a GP. But then they're good at GPs, they kick off and they get banned. So then we're back to, you know, we're back to square one with them. They do use A&E inappropriately. They kind of use that because they're always rocking up at A&E. But then they'll go in, they'll be assessed, but then they'll leave. They'll not stay to finish any treatments that they need and things like that. You know, we've had them come back to site with cannulas still in, like, what are you doing back? Because they just up and leave. They get asked to leave a hospital because of the behaviour. I totally get that. And you know, things like mental health support is critical for these, because that is the underlying thing with a lot of these. Their story could be any of us around this table. They have had some horrific things happen in their life that they just don't address. Well, they do address it, but they address it through drugs and alcohol. They don't address it where that we might address that behaviour. And ultimately, I mean, it does touch you, because all they all said to me, and one said to me this morning, all I want is to be loved. I just want to be loved, you know, and it's quite hard when they say things like that to you, because obviously we can't say we love them, but So it is them challenges. What worries me is I do think we need a better whole systems approach to this. You know, once they're housed, that's great, and good stable housing is the foundation to everything in terms of being able to access healthcare, drug and alcohol. Ultimately, work. A lot of these have worked in past. They could get back on the feet and work if they'd addressed some of them problems. The worrying thing for me is we've got a number of rough sleepers out at the minute. They've got significant health needs as well, not accessing services that we need to try and engage in services. Luckily, Recovery Steps, our drug service, they've got a nurse. She will come out with us on the streets and help us try and assess the kind of health needs and what they might need and try and encourage them into health services. But I think what worries me ultimately is the number of deaths we've had recently. So since March this year, there have been 7 deaths of people that have been in our service at some point. That's a mixture of things like drug-related deaths, suicide's quite high in our client group. So it's not that they're dying necessarily on the streets. They might have gone into services, but they're still dying. And since we started monitoring deaths through our service in January 20, we've had 36. So it's quite high. Rough sleepers die a lot earlier than other people. You know, the average age for a male is 47 and a female 43. A lot of the rough sleepers that have died recently are very young, which worries me as well. So they're all the things. But like I said, there's lots of positives. The health integration team have been great. They're up on site. They're giving us advice. We're trying to develop that more holistic support. We've got a really good relationship with adult social care now. We sit once a week with adult social care's front door to give advice about homelessness, homeless prevention. They give us advice about whether to put things into safeguarding and things like that, which has really been beneficial for us. We've got our vulnerable adults panel that we take our really complex cases to, and that helps us kind of think about how we support them in a more holistic way. And like I said, we've had some real successes. We've had a couple move on from Queen's House and they are engaging in services. They've got their own property. One of them's back volunteering. So, you know, when it works, it works. But it's I'd like it to work for everybody in my eyes.
And that's a very good note to sort of end up. I mean, first of all, I think I just want to say huge thanks to you and your team, because it takes some determination and some hopefulness to work and passion to work alongside people that both are potentially at risk of homelessness, but also, and we've got the DPH report around cost of living crisis, haven't we, later on the agenda, but also about those that have often, I mean, you know, I've sat with a number of these individuals, taken them for a cup of coffee and all those different things over the years, but to really understand the trauma that people have experienced, so the significance of earlier help services for children and young people and adults, really for ourselves, about how we get that right, is just so important. But I heard a bit of an ask there about how, what does a really fabulous and great look like for us? What more could we do? But before we go to that, let's open it up for any further parts of the conversation. Jill?
Thanks for that. It's hard, isn't it, to listen to that? You know, there's health and social care professionals sat around this table, but we know that that's reality, what you're dealing with, and certainly I'll get feedback from the HIT team and tissue viability as well, who supported some of the work. I suppose one of my questions is thinking about that those underlying issues for those people that you're dealing with on a day-to-day basis, thinking about actually what the other offer is. So I heard you say a lot around actually their compliance, which is always problematic, we know that. So it's not that the service is available, but actually are the services responding in the right way to actually what their needs are. And I think there is something a little bit more that we could do around that, around thinking about, I'm not saying setting up a separate service, but as core services, how do we respond in a timely manner? And how do we support those people where they're at? The other thing I was thinking about, James, as well, is around social prescribing as well, because obviously you've got links in ED around your high intensity user group, but actually from a broader perspective, linking with primary care and the health coaches that we've got, is there something more that we can do around that lower level, softer approach around support?
Yeah,
it's really helpful. Jill? Richard?
Yeah, I was thinking that, you know, if we're planning for the next sort of 10 years in Barnsley, what other things we can do to stop the next group of people becoming homeless, you know, given that drug use, mental health issues, traumas are sort of well established, recognised risk factors. So people already in that position that clearly difficult to help at times, but can we stop the next generation?
Yeah, I think that's definitely my focus. So we're writing our homeless strategy at the minute. It's true. We have to have a homeless strategy. And the key to resolving any homelessness for me across the board, because obviously we deal with complex people, but we deal with loads of, you know, just general people that fall on hard times and become homeless, families, things like that. The key for it for me is prevention and early intervention. We need to know as soon as somebody's struggling with their housing, because we can get in and help them. Often we can save tenancies, we liaise with landlords, we can pay rent arrears off, we can get in and look at things like hoarding and the housing conditions and help to address that. But we need to know early what, from our stats, because we have to do, everybody does stats, don't they, back to government. Our stats still show us that too many people still present in crisis. They wait until they're actually evicted or bury, and we all do it. We all bury his head in sand. It's easy to ignore it, isn't it? But for the complex ones, for me, we need to be looking at our trigger points for us sleeping and things like leaving care. So we need to get in much earlier around that. Complex families that might be struggling, that kick the kids out at 16. Prison release, hospital discharges are, you know, because often people will go into hospital, but we're not told till the day they're being released that they're going to be released no fixed abode. So then they just turn it up our office, and there's not a lot we can do on the day. You know, if we knew when they went in, if they're going to be in for a lengthy period, we can start and work with them. So I absolutely agree. Prevention is key for this across the board, really.
Thank you. Martin.
Sure, I just wanted to get an idea of scale of this problem. What kind of numbers are we talking about?
In terms of homelessness generally, we probably get around 2,000 people through our service every year. But that's everybody, you know, in terms of families, singles, couples. Some people are easy to resolve. In terms of the complex ones, and this revolving door kind of client group, I would say there's probably around, it's not massive, it's probably around 60 to 80 come at any one time. We have to have with government what's called a target rough sleeper list, the ones that present the most, that have been on the streets for a long time. And at the minute, that target list has got about 40 on. But then we know there's others on periphery that are either in prison at minute or, you know, bobbling about. But they're the ones we know about. That's what worries me. There's a lot of sofa surfing, a lot of people around that we don't know about and haven't come to us yet for support.
Thank you.
Bob and then Leslie.
Yeah, thanks. It's really helpful to get the insight. I think from a hospital point of view, it's very person dependent on the response that the individual gets and depending on the time of day and the week and all the rest of it. So from us, I think having a clear approach that we can coach people through and they can refer to, because obviously we're open 24 hours a day, 7 days a week, and we're certainly used to people with chaotic lives, and there's a lot of staff have a lot of compassion in the face of quite a lot of disruptive and aggressive behaviour at times. You know, I think on the gastroenterology ward, we do have real ongoing issues with people, you know, in our care, despite being asked, you know, going out, sourcing drugs, alcohol, you know, bringing it back on site, and they've got a real duty to everyone kind of in the area. But if we can work towards an agreed way of working that we can train people through, we would do it. Brings to mind the issue around the rough sleepers, you know, particularly when we're talking about in COVID, there was a bit of a narrative from certain team, you know, security, where we need to push people this way and that way. And we said, well, no, we need to be kinder. You know, we work with the team, you know, with a support card. You know, in this situation, this is what we do, and try and guide people to the right place and support people that are trying to sort of sleep within the hospital grounds and stuff like that. So I really like to think we could work with you on it.
And if you've got people like that that are rough sleeping around the hospital, we've got an outreach worker. I'm happy to dispatch him to
I think that's
alongside yourselves and your guards to speak. We'll probably know him, so we can support you with that, definitely.
Leslie.
Thanks. Can I ask Michelle? I mean, it's really powerful stuff, this, and if you want to look at people who are excluded in society, then you know you're right there, aren't you, at the coalface with it. What in terms of voluntary and community, because I'm new to Barnsley, so what in terms of voluntary and community sector support is there available that might be able to do some more kind of hands-on stuff more regularly. I appreciate that, you know, you need medical services as well, but just in terms of maintaining people at a level that they can manage, you know, is the stuff around in Barnsley that can help?
That's something that we are looking at actually. We do have, we've got a lady, a volunteer lady that comes from one of the local churches. She comes every Tuesday up to Queen's House and cooks with our clients, and she's absolutely fantastic. And the clients love her because she's not authority and she's not kind of telling them off like we might be. They absolutely open up to her, and she's brilliant. And this is something we want to develop. And funnily enough, I met with Stainbury Rotary Club yesterday because they really want to support the homeless, and they came to meet me about how they can help. And they were talking about we're trying to do this gardening project up there with them, and they said we'll come and do it. We've got volunteers, and they were talking about particularly the male volunteers, because most of us are male up there. We do get women, very complex women, and that's another story. I really worry about complex women. And they've said that they could be really good peer role models, and that's what a lot of them need. They need that kind of role model work. So we are looking at working with them as well. I'm also going to meet with Barnsley VCS to look at what else we can do on that kind of softer side, because what we need to do with a lot of them is fill the days, you know, so they're not sat taking drugs. You know, and like I say, a lot of them have got such skills and potential, but we just need to try and harness that and not be dealing with crisis every day that we do.
Yeah. I've just spent 30 years working in Rotherham, and I don't know whether you know Shiloh in Rotherham.
Yeah, they're brilliant. I'd like them here.
You know, well, this is what I'm asking you really. You know, how do we get a similar sort of place? It's a place to go, isn't it? It's a safe place to go. It's a place to go that keeps you occupied with positive stuff. And it is about love and companionship as well. And I think, you know, services can do part of the job, but actually that building relationships and that sort of stuff and caring about people day in, day out as a person rather than looking after them as a service, I think, you know, is really what's needed. And I just wonder whether there's opportunities to do some learning from other places, really.
Yeah, I totally agree with all of that. And I think Shiloh are brilliant. I'd love them in Barnsley.
And then Madway.
Thanks, Wendy. I'd like to go back to Bob's comments actually about when this client group come into hospital, because the health and their access to healthcare is so important, you know, to give them all that they can access that. If they know that they've got addiction problems, complex problems, a lot of them have got severe mental illness problems, so they find it hard maybe to be in that situation anyway with professionals. They need to get out to get their addiction fixed that day, and then so it's a problem for the staff in trying to cope with if they're coming in and out, or people are bringing drugs or drinking for them. But there must be a way that can be managed for 60 to 80 complex cases in the borough. And it's giving them that hope that you have got an addiction problem, but we're here to support you, we're here to help you, we're here to look after your other health needs that are going on, maybe nothing to do with that problem. They may have heart failure or something else totally not related to that problem at all. So yeah,
I know I'm just really conscious of time, but it's just a testament to how interested and how committed people are to get alongside you, Michelle, and try and make this a better situation to improve people's lives fundamentally and help them to recover. You said people worked, and I'm confident that people can get back to work. It's just how we work alongside them. Very quickly, Jane, and then Madway.
To discuss how prepared we were. Based in our big meet. Early on in that meeting, we identified it was actually quite low, the risk that we would have such a large group placed with us in Barnsley. What we did then discuss is about actually the cohort of people that we do have living in multiple occupants, whether we could actually work much better together. And it was felt that there was real merit in this group that we've set up, extending the membership, but also
to keep meeting to improve processes, pathways and strengthen our relationships with our cohorts. But then we started to discuss about people who are homeless. And actually, is that something else that this group potentially look at and explore how we would do exactly the same as we were looking at the migrant and asylum seeker population to improve the relationships and processing pathways between us. So our next meeting is next Friday.
Happy to invite, because in our team as well, which I didn't mention, we've got the refugee integration team as part of our homeless team, because we are dealing with the Afghan, the Sudan, the Ukraine resettlement, and also we are the first port of contact every time an asylum seeker gets a positive decision in Barnsley. They're sent to a homeless team because we need to look at the housing. So we manage and support all that kind of MEAS process and asylum process as well. And we've got support workers in our team that are really experienced at doing that. So yeah, I'd be happy to join anything like that. That'll make it better and easier for them. Yeah, it's brilliant. Thank you.
I just wanted to add what Jill and Bob were saying, and a lot of the times they do come, they get on a bit of an even keel and they drop off. So and it's a recurring cycle, isn't it?
Yeah.
So this is where I think if there is that one person who could be there with them and for them, whether it is voluntary sector or whatever. And I think I'd like to say that I don't think there is a reluctance from medical teams to engage with them in any shape or form, but it's just that it's the compliance and wanting to just stick with whatever has been put in place for them. Because we have one patient I've discussed with safeguarding and everybody, and is a young boy we want to help, but I think he can get quite aggressive and doesn't engage with district nurses, tissue viability nurses, and they're scared he has knives with him.
Yeah.
Just as a threat. But what I'm saying is, I think we're all there, but we're probably working in as patches.
Yeah,
rather than together. And if there is something that can actually bring everybody together,
yeah,
it would work.
Definitely. No, I agree.
Thank you, Michelle. I mean, just to reflect very quickly, we seem to have some actions there, haven't we? There, I think quite a few. But I think what you're hearing is a real will from around the table to get alongside you. It feels as though there's something about just us taking stock a bit with Michelle across the hospital, primary care, community health services, and the voluntary community sector, as Leslie said. And perhaps we can just galvanise a bit of a conversation to say, you know, what can we do? And we're happy to have that back here as well. Or we certainly take it into the place partnership delivery group, can't we, in the first instances? So we can have a look at that as part of our overall planning ahead. There's obviously some sort of short-term bits about connecting social prescribing, James, with Michelle. I think that would be quite a helpful thing to do. And clearly there's an offer from Jane about let's get that conversation moving as well. So and then ask, I guess, as you know, Michelle's working very hard in terms of the homelessness strategy, and particularly the prevention arm of that we really we all need to put our shoulders to the mast, don't we, to ensure we've got doing the right things for the right reason to deliver the right impact.
Yeah.
So thank you again.
Thank you very much. I'm going to leave you now. That's all right.
Yes. No, thank you.
Well, Michelle, see you later.
Michelle, thank you. It was important. I know I'm always like this, aren't I? I'm never on the agenda timescales ever. So apologies, everybody. But how can you stop a conversation that's like that? A bit of a another bit really into that. But I've heard some of those stories and been sat in cafes with people telling me about how tough times they've had over their lives. So important. Okay. I think we're now on to item 6, questions from the public. So we welcome again. We've had a number of questions into about 14 or so questions into our committee today. So as ever, we will respond to them all in writing, but I am going to pick out a few today just to talk through. So one of the first questions, which was the additional public question that we didn't quite get to on the 30th of March 23. And it was a question about the assurance report and the Barnsley involvement in the equality group. And it was a 3-part question. Why did the public and existing equality forums know nothing of the involvement plan discussed in the assurance report? How are the public and existing equality forums involved in the development and approval of such an improvement plan? And third, why does the Barnsley involvement in equality group not include anyone representing the voices of the public or the existing equality forums? So our response to that is that the involvement plan, as the actions outlined in the Barnsley Health and Care Plan, which had been drafted informed prior to the meeting today. So there is most definitely a piece of work that we need to do in terms of the health and care plan and engaging with the engagement participation group at Kirsty about working that through, but I'll come on to that a little bit more. The equality engagement group is developing the plan. It's made up of colleagues working across the partnership in addition to Health Watch. So there are a number of members of that engagement and participation group that come from our provider organisations and the VCSC and Health Watch as well. So they've developed the involvement plan to focus on working better together, excuse me, and build on the work on the way we work alongside local peoples and communities. And the group has a membership of officers who work with and link to a whole range of forums. It does through the member partner organisations who have a role, link or responsibility for some of these forums. One of the things I think it's really important for us to do, and I am committed to doing this really, is that I think we really do need to have a rich conversation around our approach to engagement, co-production and participation. I'm absolutely convinced that's what we need to do. Kirsty and I have been having a bit of a conversation about that. So we plan, if it's okay with committee members today, to bring a substantive item into the July committee, which is a bit more of a reflection about what engagement, participation, co-production have we done to date, and that'll be reflective of all of our organisations, not just the ICB. And actually, what are we saying is our approach? And I think that's going to be a really helpful conversation. I've asked Kirsty to work with the Engagement and Qualities Group. Of course, Adrian, you'll be part of that as well, in terms of bringing that conversation forward. And we'll have a long conversation about that at the July's committee. I also note as well that the strategy, Kirsty, the ICB strategy around involvement, it expires in May, doesn't it?
It does. It's due for a refresh.
Due for a refresh. So there's a timeline that Andy Ashcroft in the ICB is working on the development of that. We had another question. There was a question that was around generally feeling that the responses to public questions at the last meeting felt disappointed, that you felt disappointed about that. I'm really sorry about that, and dismissive and disrespectful to the public you serve. I'm really sorry that you feel like that, and I wouldn't really want you to feel like that. So there's something about how we might work better together. So perhaps there's something that we need to have a conversation outside the committee about that. And I am aware, I know you've asked about the conversation that you're having with Piers Butler, and I think that's a really helpful conversation. So I'm look forward to the outputs from that as well. And let's have that conversation about how we work more effectively together, and we'll have that broader conversation at the July committee. And the third part of that question was, are you aware that despite all the engagement reports, public questions to our Barnsley board meeting, the Barnsley board meeting is the only open, transparent and direct mechanism for Barnsley people to be involved in your decisions. Hence, there's really having a deeper look at that in July, and committed to doing that. I would also say in response to that there are a number of examples, I think, where members of the public have participated in shaping services, whether that's be through the work of SWIFT, the work of primary care, the work of the hospital, indeed mental health services, the hospice, and other adult social care, children's social care. So I think there are a number of examples. So, for example, the carer strategy work that was really co-produced really with the carers group. The work on the Dementia Alliance, that's very much led and co-produced by people of experience of that and their loved ones as well. So there is a lot, but perhaps we're just not good at saying what we're doing and what difference that's made. So that there's more that we need to do with that. And there was a question about podiatry, Jill, if you would.
Thanks for the question. Actually, it's brought to the forefront a couple of issues that I think we need to look at a little bit more. So, just in terms of context, we were re-specified in community services in 2019. Podiatry were part of that re-specification from the then CCG, and at that time, actually, we'd got a podiatry service that needed to modernise, I would say, because there's been a number of changes over a number of years. We've provided podiatry for a long time in Barnsley, and the landscape, I think, of the patients and clients that we come across now are becoming much more complex. We've also seen an upward surge in referrals of about 13% post-COVID as well. So obviously the service, as it currently stands, has had to make some adjustments in terms of how it's delivered. So there was 3 specific questions. One were about Barnsley Podiatry Service being understaffed and patients with long-term conditions not being seen on a regular basis and being discharged from service and then having to be re-referred. We're currently undertaking quite an extensive review, and we've got some peer support from Rotherham to actually take a look at our service locally. We've done some recent mapping. Actually, that shows that a lot of people are remaining on the caseloads for a long time. We've got some people that have been on there for 15 years, so we don't discharge people lightly from the service. We've also, around the issues around the court around, increasing number of falls, we'll have a look at that in terms of the work we're doing on falls pathways to look at what the evidence is to support that podiatry is a bit of a gap in service around that. Obviously, some of the analysis that we've carried out with the team so far, together with the team, I have to say, is that the waiting lists, although they're quite extensive, we're managing them downwards, set against that 13% increase. And currently, in terms of staffing, I think, the quote around being understaffed, actually, we've only got one vacancy actually within the service. So we're almost fully staffed against the money that we've got to spend on podiatry in Barnsley. We've got a current gap in, or we did have a current gap in clinical leadership in there that's been out to advert a couple of times. There's a national problem with podiatry. A lot of podiatrists qualify and then go out into private practice, so they're hard to retain within the NHS. I think the other thing is we have got a couple of maternity leaves. We've got quite a young female workforce in podiatry, and obviously that's something that we look at, and we've had inward investment inwards from Swift to actually cover maternity leaves, which we don't always do in every service. The other area is around the policy, and it isn't a policy as such around discharge. We're following NICE guidance and good practice guidelines around podiatry, around how often we see people and when we bring them back. And it's very much based on clinical judgment and need. But obviously we're doing that with the backdrop as well of dealing with obviously an increased referral, and also the push as well around, moving more people around, supporting them in self-care and actually patient-initiated follow-up as well, which we're doing a piece of work on. The other question were around other South Yorkshire trusts paying financial incentives. And this has actually been an ongoing issue, which we've raised with Wendy, and we've raised it with South Yorkshire ICB through the workforce group in actually, actually working in an open playing field in terms of recruitment of staff. And I think we do have to accept that, sometimes there are sexier posts in teaching hospitals. There's more scope for development in teaching hospitals and other areas. But actually our retention rate around staff in podiatry is absolutely excellent. So I hope that goes some way to, the other thing is, as part of the work that we're doing on review, we've got a small patient and care co-production group. And if anybody else wants to join that, please contact us to actually get involved in that piece of work, because it's very much as part of the review, we're doing co-production alongside patients and carers.
I think Nora was expressing that she was maybe interested in joining there or thinking about that. That's great. Thank you, Jill. It's a very comprehensive response. And the final question I'm going to pick out for today is, there's a helpful question. Given the current and pending reduction in the running costs of about 35% facing South Yorkshire ICB, how do you intend to ensure that the above has a minimum impact as possible in the running of programmes at Barnsley level? And equally, how do you intend to ensure that the South Yorkshire ICP strategy aims and objectives will be achieved as planned at the Barnsley Place level? So, there's no doubt that a challenge of 35% is a tough ask for us in the ICB. Originally 30%, and obviously the additional 5%, because we haven't had the assurance that the redundancy costs will be met nationally. So 35% is what we're trying to deliver. It's in its consideration of how it's going to approach that. The principles of subsidiarity remain very true. So how do we try and ensure that care is as close to individuals, neighbourhoods and communities as possible? So we're trying to really think that one through. And that basically the ICB currently is going through some sort of organisational design, really, about how it's going to stay true to its strategic priorities and the whole reasons why ICB were established in the first instance, whilst having as purposeful an approach to its resources as it possibly can. And part of that really clearly is having rich conversations with our providers around the table, including local authorities as well, about the art of the possible in that space. How do we really be clear that, you know, the ICB is doing things that only the ICB can do, and how do we make sure that all of our assets across providers and the ICB are used wisely and carefully. So that's a piece of work that we're on with at the minute. So of course, we remain committed to delivering against the ambitions of the ICP. We've got the health and care plan on the agenda today for our considerations, and we'll be having some further conversations during June about how we get ourselves organised with that plan. And you know, there's a set of really bigger priorities that we need to focus on, and that's on the 13th of June. So I'll leave the questions there. There's no way I was ever going to get through 14, but I think some of them are a little bit sort of connected as well. So we will respond to all of those questions in writing, as you should quite rightly expect us to do. Right, thank you for that. In terms of item 7, we've got minutes of the previous meeting held on the 30th of March. And well, we have to accept them as a true record. But I believe, Martine, you've got some observations, you want some additions. You want to just share those quickly with us?
Oh, you put me on the spot now.
Okay.
I did an email to Kate at the time. I've got an email. It was about unsustainable funding model for the hospice.
Thank you.
Thank you for reminding me. Yeah, I'd asked for, we'd had a conversation, I'd asked for opportunity to lay out the challenges around the long-term financial stability of the hospice. And we got to the point that, you know, I'm going to come and present something in June or July, I forget now.
That's right. We're going to have a good conversation at our development session in June about the hospice and sustainability.
And it's about addressing the national funding model and gaining support for that. Yeah, thank you.
Thank you. Is there any other, can we, with that amendment, can we accept the minutes? Yeah. Let's go to item 8, the matters arising log. With, I think, from majority incomplete. We've got number 19 there, which is still ongoing around quality. And Jane, any particular progress on that at all? I know I've got quality on the agenda, obviously, later on.
Yeah, I mean, with regards to the committee itself and the reporting, we're still obviously like it's gaining momentum now. I think we now realise, we understand where we are with regards to the quality committee and what its role is and what sits within each of the providers. So it does feel as if it's gaining momentum now. So work is ongoing. July to really try and make it as succinct and efficient as possible.
Thank you, and I know colleagues, you know, chief nurses across our organisation is really trying to get that right. It takes all of us. It's probably also worth mentioning at this particular point that I'm aware that Pierce Butler has commission might not be the right word, but is looking, Leslie, isn't he, to do a bit of a review of the overall governance. Leslie? You're on mute, Leslie.
Sorry, trying to two computers. I'm technically incompetent. Yes. So as part of the organisational design work that Wendy's mentioned earlier, there is an ongoing review at the moment of the governance structures. But I think in terms of quality specifically, we did a lot of work sort of in Q3 of last year into Q4, and certainly looking at the item that's on the agenda later, it's really useful to see how that escalation from local to local place to the sort of ICB committee is a lot clearer now, which I think is what we were after, wasn't it, Jane? You know, understanding what needs to be looked at place and what needs to be escalated up to whole system. So that's really good. In terms of the quality, patient and public involvement and engagement committee, I've got a meeting today with people to discuss what the future of that might look like. So all of that work's going to happen, as you said, Wendy, over sort of the remainder, what bits left of May and into June, and we should start to see what's emerging there. But I think retaining that commitment to quality is going to be really, really, you know, it's paramount, isn't it? So I can't imagine that we're not going to have that committee. It's just how it's going to shape up.
Thanks, Leslie. That's a really helpful update. We've got number 19 there, which is still in progress as well, which is about our approach to risk. I'm conscious that we haven't tabled any risk log into this committee, and we do need to do some work on that. There's some further refinement, Roxana, isn't there, I think, about the risk, or indeed, Richard, about the approach to risk. We will be able to bring something forward on that in due course. Do you want to add anything to that?
It'll probably come to the July meeting. So we've done some rework of the ICB risk register to try and determine actually where does the risk sit. Is it system risk? Is it a place risk? To determine then what would come into this committee. So that hopefully should be complete. We've sent all comments back. We've met with Ruth Nutt-Brown, who's coordinating that across the ICB, Richard and I. She's taken our comments on board. So we're looking to get a new developed version for SMT in a week and a bit, I think. And then it'll come here in July.
That update, Richard?
Yeah, I think it's a tricky one, isn't it? Because we're in such an interconnected world at the moment that I worry a little bit about, say, like the non-surgical oncology question. They say, well, that's a census England problem, but the impact is on Barnsley women. As far as we're concerned, that's the people we are here on behalf of in that connection, mostly in airline. So therefore, in my head, that's a risk that's in Barnsley, and we're here for Barnsley, and therefore it should be on our agenda, even if it might not be in our gift to solve it. The consequences of it, we'll have to pick up psychological support, workarounds, all that sort of stuff. So I'd be keen that we don't hand off risks. So they're doing it over there, so we don't need to know about it.
No, so it'll be the system risk will come for what I envisage to be kind of almost oversight, and because the mitigations will be dealt with by others. So it's the risk that we will control, and we will be the ones that put in place the mitigations will come in for us to do something about, with then an oversight of the other risks that are kind of sat across the system.
That's helpful, just to get a bit of sense of where we're at with that. Yeah, you're right, Rich. It's been quite complicated, hasn't it, really, in terms of number of iterations, and quite a bit of feedback. So I'm sure that's quite right. For exactly the point that you raised. So, but I think we're getting there. Hopefully, then we're going to be at that point in July that we can bring that in. Are there any other questions at all around the action logs? Log. No. All right. I'm going to take items 9 and 10 together. In terms of a quick update, really. It'd be fair to say, as a Barnsley leadership team, our work's been quite focused of late on the health and care plan, getting that plan as focused as we can. Still a bit more to do around the priorities of priorities. I think that we've got, said earlier on in June, we've got the session in June. In your pack, you've got the Barnsley update that we tabled at the ICB. So I'm just going to pull out a few things around all of that. One was there was a description of our approach to inequalities, and again, I think that's probably an area that we do need to do a bit more work on that and focus on that over the coming months. We obviously shared news about the intensive care unit and the great conversations that took place across the voluntary community sector and the social enterprise sector as they're starting to shape their conversations about how do they get themselves organised, what are the things they need to focus on, what's that relationship with the health and care plan. So in and of themselves, they're getting into a much stronger place. You'll see that the slides that were tabled at the ICB talk about Proud to Care. Proud to Care as a brand. I mean, interesting actually, how many people have heard of Proud to Care around this table? So Proud to Care is a little bit of a brand in social care that's really been about trying to raise awareness of roles across social care, particularly in the context of the challenges from vacancies. And we thought, well, we could probably only do this with and alongside our providers. It'd be fair to say, as developing our approach to Proud to Care, that we've had greater engagement from the domiciliary care sector than residential care sector. But fundamentally, the Proud to Care approach is about trying to, Jill, I think you've been involved in, haven't you? Yeah, about trying to tackle things like recruitment. How do we be a bit more slicker around recruitment, and that's across health and care really. How do we, galvanise our actions in that space? It's about developing sort of induction and core skills. It's about career pathways. It's about redeployment. And we've been working really closely with the adult learning team in Barnsley Council around all of that. And we delivered a training programme, a 4-week induction course. We've had 30 people through that so far, which is really great, around really supporting them to think about and develop their skills around entering into care roles. And some of those individuals, have personal individual needs as well. So it's not just about the training for care, it's about how do we support them in the round. So we've done, I think we're on our fourth cohort around that. Some great feedback, and to really help us, we've got to secure some funding from Princess Trust, and that will really provide us with an additional role to work with young people aged 18 to 30. So about helping them to support and think about roles across health and care. So we're really pleased about that. A couple of other things just to mention is the intermediate care review is well underway. So we've done the analysis. We've understood what it looks like right now. We're now in the process of the intermediate care steering group of shaping what a future model might look like. And that will be a product clearly that we'll want to bring back here. Really keen, obviously, to make sure that the voice of people that draw on intermediate care are reflected in that report, and that does inform the modelling that we know we want to do. Bob, ESIS, anything you want to just mention on terms of ESIS work? And then we'll catch up later.
Just the last meeting, yeah, we really good session, good engagement. We've got a number of tests of change to take forward. We just need to agree how we do that and resource it, etc.
About that later on. And finally, some great work taking place, Jill, with your team, and certainly social care about sort of out of hours.
Yeah,
Yeah.
really good progress on that in terms of conversation around not just co-location with IR 365, with adult social care, rapid response night service, and our urgent community response, with the whole aim of keeping people at home, out of ED, out of care but home beds as well, not just ED. And actually that will come in together in a sense of purpose, using that as a bit of a base to the model of how transferable is that into daytime. And when I talk about out of hours, I'm talking about weekends as well, obviously not just after 8 o'clock. But actually, obviously, part of the estate solution for that will be working with GP Federation in terms of private campus as well. So some really good work, mapped out a really good project plan, got really good engagement. And again, some of that will be about co-designing with the public as well in terms of their insights, what they need out of hours.
So some great work taking place. So I shall leave my update there, and if there's any questions. Oh, sorry, I think Jane wants to come in. Jane, and then Leslie. Is Jane there? It's me. I've got my glasses on, so I've got no excuse. Leslie, not Jane. Sorry, Leslie.
We've both got blonde hair and we're on the screen, so you're allowed.
You do look alike, yeah.
I know. A comment and a question, really. So my comment is, I don't know who puts this report together, but I really like it. It's really clear. There's loads of information in there, but it just presents the right level of detail. So whoever does this, thank you, because it's a great job, and it really stands out to help understand really what's going on and some of the depths of work that's happening. So I just wanted to say that. My question is, because I love the Proud to Care training programme. I just think that's a brilliant initiative, and I wish we were doing it across the whole of the ICB. With in my previous hat on working for Age UK in Rotherham and working in the social care system, I know how hard it is to get people to come into that system, get the right people, and how important it is to the people who are receiving care that they get care from somebody who comes from their community, who knows when they're particularly I'm thinking of older people in my experience, but who know when they're talking about stuff, what they mean and things like that. So I think it's brilliant. I just wonder, are we measuring how many people find local employment as a result of the training, or will we be measuring that?
Yes, so we are measuring that. We're not quite ready to bring a report through because we want to really get some feedback about the impact. Have we got the induction training right? What does that look like and feel like from people? and of course the numbers about it's the convergent rate, isn't it, from attendees into people in posts. Yeah. So we will be gathering that information. Thanks, Leslie, for the feedback. Anybody else at all? So we've got feedback from South Yorkshire Integrated Care Partnership Board.
Yeah. The meeting was on Tuesday and it concentrated on the children's and young people's agenda. They informed them. I was on Marmot, which Sheena said was excellent. But they also heard about some work going on within areas, so work being done in Doncaster and around but not a lot to report, but a very, very good session on young people's.
Thank you, Kevin. It's the information's there. I should have probably mentioned actually with Michelle's update. Really, I also joined a conversation that the mayor had convened, which was about homelessness actually, and that was really, really interesting. And I think there was some commitment to take forward some of the methodology that they'd learned from the, goodness, remind me, Bob, New Yorker. Thank you, Harvard Bloomberg. They'll have Harvard Bloomberg at work and think about how we might apply that to homelessness. And that actually, at the minute, we've got four homelessness strategies. And could we think about doing, is there any do once type of stuff? How do you galvanise action?
Safe place to sleep. There's the strap line that they put to that from the Harvard Bloomberg work. Ina did share some of it with the non-exec.
Yeah,
it looks really
exciting.
Yeah, and I think there's some really good ideas and really good initiatives, but the key focus we've been working with Sheena and Alicia Sonson from BNBC is what does it mean locally and how does it link in with our priorities? So we're going to Sheena and Alicia are going to be presenting on it at I can't remember the name of the meeting, in the Children's
Trust.
Yeah, Children's Trust meeting, first week of June, and you know, Sheena stepped forward as a Barnsley representative, which is working in a non-exec capacity. So just making sure she's partnered up with someone from the children's team to support it, because in the group you've got a public health director, you've got a place director saying, "No, I could do this, I could do that," and they're in a position to sort of enact things, you know, more quickly. So we're just going to kind of work that through at that meeting, and then be able to report back in a more joined up way from a Barnsley perspective.
It's really, really helpful. You know, we do need to meld it, don't we, into the broader plans of the Children and Young People's Trust, really, and our early help work and offers. So thank you, Kevin, for taking us through that. It's very helpful. Jamie, I think we're to you, item 12.
Yep, that's fine, Wendy. And I think this will probably, or some of this will probably shared at the Integrated Care Partnership as well. So I don't think it will afford, but I know there were an intention to take the joint forward plan in there prior to then final sign off. So I'll assume that people have had an opportunity to read through this paper. I know a lot of people have been involved in the development of the joint forward plan. So just as a bit of a reminder, it's set out in the cover paper, but the Integrated Care Partnership, so our wider partnership across South Yorkshire, published their Integrated Care Strategy on the 24th of March. The joint forward plan is intended to be our ICBs, together with partners, will arrange and provide NHS services to meet the needs of our local population, set in the context of that strategy. So it's our shared delivery plan for the integrated care strategy, the ICP strategy, and it sets out all of the key areas where we intend to work. I think the paper talks through the process, so commencing from January, revisiting the joint strategic needs assessment, the baseline of where we were against key elements, talking about the approach to engagement and involvement being used to inform the strategy, but then taking that further forward. There's some specific elements in there, and then working through. So we got to the point of having a draft strategy that sets out now a number of strategic objectives for the forward plan, which I think will resonate in terms of our local plans and what's in the strategy. So first, around reducing health inequalities and prevention first, improving access, quality, and transforming care, supporting and developing our entire workforce. I think that includes across the voluntary community sector as well as within the NHS, everybody that contributes. Partnerships and collaboration to deliver our plan, digital data and innovation, and then making the best use of resources. The joint plan will set out priorities in 5 years, but we'll set out some priorities for the first couple of years in more detail than the areas that are expected to be worked upon. There have been some further system development sessions, and they continue into June around longer term relations, and then the paper sets out the next steps. So in effect, this is brought to the place committee and partnership, I guess, to consider the update and the content that is included, particularly around the progress that's been made. That'll allow us to have further ongoing engagement. The work underway by place partnerships around our plans, which is the next item on the agenda. The work that collaboratives and alliances have been doing, so our providers working together to identify where they can focus on their improvement work. And then a couple of dates, I guess, to note. So I referenced the ICP on Tuesday this week, the 23rd, which has happened. There've also been sessions with the system leadership executive, one in May. There's another planned 13th of June, and then the final joint forward plan will be presented, noting that this is slightly after it has to be sent to NHS England just because of timings, but will be presented and approved hopefully on July the 5th. I think that's all I wanted to set out the process that's been through, and take any comments that we can feed back in to that process prior to July.
Okay, thanks, Jamie. Adrian.
Yeah, can I answer that, Chair? Because obviously I was at the meeting as well. Member of the Integrated Care Partnership, just come from the hospital. The joint forward plan for South Yorkshire is going to go for consideration, not just to the Integrated Care Partnership, but to Health and Wellbeing Boards, to give them the opportunity to comment as well, Chair. That's all I wanted to say.
That's a very helpful reminder. I believe it's scheduled in it.
The 1st of June.
1st of June.
Yes.
Thank you, Adrian. Leslie?
Thanks, Wendy. Yeah, I just wonder if, I know it's there in the depth of the text of the full report, Jamie, but just wonder, in the light of the questions at the last partnership board meeting on community and citizen involvement, we've noted kind of working with Health Watch and the VCSE, but can we say a bit more about engagement and influence of the public, so that we're just clear how that's happened as part of this planning process, please?
To include that in the future paper, you mean, Leslie?
Yeah, but also I think it's worth just highlighting the work that's already been done. So obviously, there was the amalgamation of things, wasn't the Kirsty from previous work that had been done that kind of sets the scene. But I think it's useful to sort of see that actually that's ongoing, and how will that influence the shape of the plan, and more importantly for me, the delivery of the plan. Because it's not just about people telling us what they'd like to see in a plan, is it? It's also about saying, well, some of these things are quite thorny issues, and how are we engaging with the public in delivering some of these objectives that we've got. So I just think it's worth mentioning. I don't know, Kirsty, whether you want to add anything, but
yeah, can do. Yeah, thanks, Leslie. So this is it's a continuation of the conversation. I think that's how you sort of phrased it, haven't you? So what matters to me about my health and well-being, which we've brought back to this, which contributed to the overall strategy. at that point in time, we produced a strategy and we said, actually, we want to carry on this conversation. So that bit about what matters to me. And a big chunk of that was about saying, well, actually, there are some groups that in that first sort of phase of work, we didn't really go and find and we didn't hear a lot from. So we saw some really helpful common themes come through, but actually there were more conversations we wanted to have. So part of that is working with Health Watch. So our local Health Watch has been doing loads of work with local groups, going into local communities, having those really rich one-to-one conversations, running sessions. We're doing telephone interviews with, I think there's about 1,000 people. They're doing that. They're doing some on-street interviews. They're trying to get to people that we perhaps wouldn't normally get to, which I think is really helpful because it helps sort of, you know, A, it's more inclusive, and B, actually, it's not from sort of the people that might tell us something over and over again, which is equally as important. But I think there's that wider breadth of information. And I suppose the other aspect of it then is there is some governance over that. So there is a joint overview and scrutiny committee who are calling us back and asking us, how are you doing this, and giving us some real positive challenge in that space to say, actually, we think you need to be speaking to more people, or we think, you need to understand sort of the experiences of this particular group. So that's really positive, and that will get a sort of phase 2. That will be informing, this plan across South Yorkshire, the Barnsley plan, but then the next bit, like you say, Leslie, is the meat and bones of it. So, now we're going to be delivering some of this stuff. How are we going to do that? So I think that comes in the next phase. This bit at the moment is still in that, actually help us shape it. Have we got the right things? Are they in the right places? Are there things that we've missed that we could include?
Yeah, thank you, Kirsty. That's really helpful. Thanks.
Thanks, Leslie. Adrian.
Just to add to that, Chair, this work will continue until the 2nd of June. It completes there. The other 3 health while local health just also included in that. So it's getting a broader breadth of people that we find it very difficult to engage with. It's us finding difficulty, not them finding difficulty to engage with us. It's the other way around. We need to be engaging with them, not them engaging with us. You know what I mean? And it's so important. But it will also direct the 5-year strategy plan going forwards as well at the SIB level.
I will take a question one from the member of the public.
It says here, have you carried out a quality impact assessment? And the answer is no. The individual projects will do it. Well, I have noticed this kind of response in several plans. And I think maybe it's a good idea to have an overall kind of framework or guidelines for people to fill in the data that is needed, quantity or quality. So then we have a system approach. It's not about each project. We lose sight of that, and that's where inequality occurs. So we need to have a system approach. Something needs to be done.
Thank you very much for that reflection, Kirsty. Yep, happy to capture that. Thank you. On to you,
I don't think I'm getting it across 2 papers, because in terms of the joint forward plan, there is a proposal around across all of it to develop an equality impact assessment. In the section it says yes, an equality impact assessment is under development alongside the working plan. I think it's the paper on our Barnsley Place plan that says we've not done an equality impact assessment because we've identified our goals, and we now need to move on to, as you said, in the next sessions, in our development session on the 13th, the detail that sits behind that, and now we then do the equality impact assessment. So for the joint forward plan, that is ongoing, that is being developed, that's across the system.
Thanks for that clarity. Adrian, do you want to add anything else? No, it's fine. Okay. Thank you, Jamie. Have you got the next item as well?
Yeah, yes. That is our plan. And I've just invited Joe to join, Vincent to join the call, because I think we should recognise that Joe's done quite a lot of work with all of us as partners over the last few months to try and pull this together, identify our priorities, working with the delivery group and all key partners. So we have been on this journey for a while to develop our health and care plan. So that's the Barnsley Place Partnership Plan. It's not the opposite of everything that we will do. It are the areas that we identified we wanted to focus on to add additional value as a partnership. To inform that, and there's another sort of document that is attached which we're asked to note and approve. But there will work also undertaken by the Health Inequalities, Health Equity Group to develop an approach to tackling health inequalities in Barnsley. So as you get into the content of the sort of written report and the detail behind, it explains that three-tier approach to tackling health inequalities and how we're going to address that. That work has informed some of what's included within the Barnsley Place plan, including our priorities and enablers. So that is pretty much where it is now. I think what we need to do is, and it's brought here for us to agree and sign off. We'll then publish the plans, and there's details in the paper around how we'll do that. And then the work that we've started is on developing the detail behind that, how we'll take that forward, what else we need to do further. So there are 3 documents that are attached, each for us to know. So the first is a summary. If you go in the same order as me, but it's a summary that sets out the 5 goals that we've agreed, highlights why these were identified as our priorities and how this will support our communities. So I think recognising the sort of key areas that we take forward. On the back of that, then there's a little bit more detail around each, setting out the key objective, the areas that we've agreed that will contribute towards delivering together, and how we'll measure our success. Because I think if we're doing this, and this is going to be our priorities over the next few years, we need to know whether they have made the impact that we expected. We've then got the sort of full document, so the slide set that talks through our vision, aims, objectives, and those goals and our approach. What's included in there is a little bit more detail about the enablers, so the things that we need to have in place to help us to deliver against those goals, and that includes our workforce planning, workforce development. There's information around how we approach engagement and develop our engagement and involvement work, estates, which we touched on around one of the issues earlier, digital, closer working with the voluntary and community sector, and those sorts of things. So those are all set out in the plan with clarity around why we've agreed those. And then the third document, which we're asked to note, is the Tackling Health Inequalities in Barnsley report. So hoping people have had a chance to read. I think people have come along the journey with us to get there. So the committee partnership are asked to approve the health and care plan, this headline plan as it is, and the Tackling Health Inequalities in Barnsley report. The plans to publish these as set out in the paper on our websites and share with stakeholders. And then I guess we just need to agree, if we're signing this off as a plan, how we want to share this out into other partner boards, provider boards, etc. That's it, Wendy.
Any questions at all around on that, Richard?
I think that overall, I think it's a really excellent piece of work, and a bit reading it again today, just I don't know, it feels slightly contrary to other things, is the grow our workforce bit. We've heard earlier, we're cutting 30% of the ICP staff. And when we put our financial plans in over the last few months, we had considerable scrutiny on the pay costs and considerable scrutiny on what that meant in terms of workforce growth. So, and yet then our aim is to grow our workforce. And I know it's unpacked a bit in the words of it, beneath it. But what do we actually mean by that? Do we mean filling vacancies? Do we mean there's a whole bunch of stuff around how people work, and whether we can find better ways of working, new types of roles, those sort of things. But grow sort of gives a sense of more, and it may not mean more, but I just want to it feels slightly at odds with the other things that are going on. And we've got quite a large financial deficit across the NHS. So I don't know what the answer is, but grow sort of implies more.
Yeah, that's interesting reflection, that, isn't it? Because from a social calendar, I do want to grow, the workforce, because we know that home first means that we need more capacity and capability in that sort of space, really. So grow means is the right term for myself, grow and develop the workforce. But I do understand, yeah, I do appreciate that sort of quandary, isn't it? It's a bit of a quandary.
It's a good challenge.
It is really, whether or not we need to think well, I'm open to any other suggestions about how we might frame that, Bob.
Yeah, I think it's a fair choice.
Isn't it? Yeah.
I guess I've got to tell it because he's my boss. But part of the genesis of it was with definitely see more information. So definitely understaffed in certain parts of the health and care economy. That's part of it. Worried about the age profile of staff. We've got a real loyal local workforce that have served us really well, but actually they're coming to retirement. I mean, we experienced that ourselves at the hospital. So I think there probably is a better way of expressing it, really. And we really want to develop employment opportunities for the local population as well. And I think grow also means personal and professional growth. Yeah. So probably in terms of shaping our approach, we need to express it a better way because people might get the wrong impression.
Appropriate, because actually, as things changed, comment was made that there are some bits of our system where we know we do want to grow. There's others we want to change.
Yeah.
And there's others that mean in order to do that are going to have to contract. So it's about right sizing and appropriateness of workforce.
Maybe it's development. Snap. Maybe it's development of our workforce might feel a bit better, because that's personal and that's numerical if that's right for yours. But would we be happy to change it to develop our workforce? Yeah, Joe, have you got that? Yeah, in terms of it's with us. Joe, do you want to add anything in terms of the plan? And I hope you did hear the huge thanks for the hard work in convening lots of conversations to get us to this point. It hasn't been easy, but go on.
No, that's really helpful, and I think I agree with Richard, and I think probably the overall health and care workforce will grow, but it certainly won't be growing in all parts of it. So I think better language makes sense. So yeah, I'll make that change, and thank you for the other feedback. It's much appreciated.
Roxana.
And this may be me, but I like the health inequalities report that's attached, but how the two things need to link together and join up, I struggled with a bit more in terms of how the things we're going to deliver will actually impact on reducing health inequalities. And so how do we join those two bits up together, Joe? Because there's lots of information in here about where we are now, but not necessarily then what the things will deliver and how that will then impact on improving that position.
My initial thought would be, I think this is where we develop our outcomes and our measures, and that will show us the golden thread across. Barbara is doing some really good work with the GFP, and people might have seen the draft outcomes framework associated with that. I think we need to be looking at that and mapping that down to our place, and there might be other things we want to actually include or emphasise, but that should be the golden thread through those documents.
There's some thinking and consideration about that we need to take forward, and that's an element that we need to face into on the 13th of June when we meet. Bob.
Just reflection on the question you asked about how Jamie asked about how we bring it into organize, because there's the wider question around engagement that we've already talked about, but specifically about bringing back into organisations. I think we've done this, and when we've done it in the past, it's been really good, because I know talking to Salma and others, we've done it this way. Is I think that organisations need to own this plan, because we've all been involved in developing it. But it is good. I was thinking about presenting it to our board. It is really good when someone from the place team comes on to answer any questions. I feel like it's up to me to present it to our board, but almost co-present it and answer any questions, and that people can. We're very linked into the work, but people can ask questions and kind of make that bridge across to it. So it'd be good if we did it in a consistent way.
Yeah.
So, I mean, we did that, didn't we, with the almost the governance papers, didn't
It was
we?
good,
It was
it
very
was
much a
good.
joined up effort. So let's do the same for this. It's a good suggestion, really. So we've got an amendment to make in terms of the language, grow to develop our workforce. And then there's a bit of an implementation plan about basically taking it on the road, because we need to update the website, don't we, Kirsty, and other things like that, really. So I think kind of just sort of task maybe Kirsty working with Jamie to think about how we, what's the plan for that? Because we need some scheduling into partner boards as well.
Do we need to think about the governance framework that will support the plan as well, that needs to sit alongside this in terms of, because actually we've not yet identified SROs, we've not set out what the framework will be by which we will operate in terms of how this board will then become assured that we're actually delivering the plan. So
do you want to give an update about where we're at in terms of our thinking?
yes, so we have we've worked through the plan and tried to align each one of the plans to where we possibly can existing groups, so we're not creating a whole new industry, and that is just currently I've just been doing it actually with Jane and Katie, just in the process of being written up. So we're trying to align the complete governance approach. We want to set that out very clearly alongside the plan. So each one of the actions within the plan will have a very clear line of sight in terms of where that needs to report to, and then how we will need to capture data intelligence, etc., to ensure that then this board can be assured around where it is against that plan, so that any one member of this group will then know where we are against each of one of our priorities at any one given time. So that's the plan. We have still got some gaps where we think, actually, do we need something different, and do we need to develop something different? But that'll come for a discussion, I think, in the Place Partnership Delivery Group for some ideas around what we need to set up in that. So we're going to leave it as kind of a bit of a raw piece of work in terms of this is where we've got to, what do you think, where do we need to change it, and then take it from there.
So could we, I'm just thinking about our forward, until the 29th of June, and we've got that development session, we'll probably come to onto this later on, we've got a couple of items for that. Can we just give a bit, we'll be in a position to give a bit of an update about how we got ourselves organised? So we're going to organise ourselves on the 29th.
Yeah, I think we'd be good to go on the 29th, yeah.
And because we can have a bit of critique, can't we? A bit of check and challenge on that, really, in terms of being as smart as we can on delivery. Thank you for that update. It's very helpful. Okay, item 14. Julia Burrows, our Director of Public Health, is on at the moment, so is unable to be with us today. But yet again, we've got a great report from our public health colleagues around the cost of living crisis, and it makes for a tough read, doesn't it? I think when you read through it, because it really sort of brings to life the effect on individual families and communities, and how people really are making choices between energy and food still, and you know, what a tough, difficult place for people to do. And I do appreciate that plays itself out, doesn't it, in the services and the supports and the conversations you were all having with people every day, really. I mean, it also really brings to life, doesn't it, the relationship between you know, less money, or you know, less money in your back pocket fundamentally, to your health and well-being, and how those sorts of challenges can really have a negative impact on people's well-being. And I guess, you know, as we all know Barnsley pretty well, that will affect some neighbourhoods more than it will affect others, you know, as we understand. Nevertheless, there's some good messages in there, positive messages that we should take collective pride in, really, around the fact that we worked really together on the more money in your pocket work. And, you know, thanks to, I've said before, thanks to colleagues around this table, and to see that even 20% of the population were accessing that. And that was more money in your pocket, if you remember, was that composite product where we're bringing advice and support for people that might be struggling. And that we did allocate 1.1, I think it was 1.15 million out to community groups in terms of trying to build capacity within community groups to try and support people through this tough time. There are some other great things that Barnsley do. I mean, the Healthy Holidays scheme, I mean, was just been a great scheme. For those that don't know what that is, that's really about working with community organisations, really, to bring families together, really, to be honest, and support them during the summer holidays with access to good food, blended with some great activities as well that go on during those healthy holidays. And I've also mentioned the contribution of our community shops. I mean, hands up, who's been to a community shop? I thought you had Bob, Jamie. Now, I would recommend that you, if I could get this board in a community shop room, I would take it into the community shop room, and we need to talk about this later on. But please do try and join and visit one of our community shops in either Gawthorpe or Athersley. We're very proud to get the first one up and running back in 2013. And it's a real great way whereby people can access food, low-cost food. It prevents waste, but it also blends in the skills and personal development, confidence, all those sorts of things, social isolation. So our pictures to you, if you don't get a chance, pop out and have a spend some time in one of them, and the people that use them, because I think having a cup of coffee with some folk that use those services is very enlightening. So you know, please do that. More than happy to. We'll share a contact actually if anybody wants to take up that offer. Got some contacts. So yeah, there it is. It's great work. I don't know whether you've all taken it to your partnership boards. Is it a project that you're planning? Not to be particularly Richard, who's going to be there. Are you taking the report, or have you taken it?
Team actually.
Right. Yeah, so just an ask and a reminder. If you haven't, just take it through your individual organisation's governance. Any questions at all? Julia's basically said she's happy to have any follow-up conversations with anybody on the back of the report.
Can I just add, it came under my portfolio till recently. So we were really pleased that the Director of Public Health, Julia, chose this to concentrate her annual report on, because it has been the biggest impact on people, you know, this cost of living crisis. And as a local councillor in Royston, we have got services provided through the money that's been available through household support grant and other means. And it has helped people, and it's made a big difference. And we're really proud of the staff for stepping up, you know, and pulling it all together.
Yeah, I mean, we'd just like to record our thanks to Jane Hellawell in particular as the head of service within Julia's team that's really done a huge amount of convening and, again, conversations and working collaboratively across the community sector to really, and partners, to get us to that page. So I think we should just record our thanks to Jane for her work in that. Thank you. All right, I think we're over to you, Jane. The BCSE MOU.
Can you see me? Because I can't see anybody. I can hear you, but I can't see anybody.
I think, oh, you're back. Yes, we can see you. And
Lovely.
hear you.
Well, I'll persevere then. So what I've been asked to present is around the Memorandum of Understanding for the ICS BCSE. So NHS South Yorkshire Integrated Care Board has adopted the Voluntary Community and Social Enterprise Sector and Integrated Care System Memorandum of Understanding, and there's a paper on page 155. So the Memorandum of Understanding came through a series of co-design workshops with the BCSE across South Yorkshire, and it went to the System Leadership Executive on the 8th of November, and it was agreed that it would be discussed within place. The MOU sets out the high-level relationship between the BCSE and ICS, builds on existing place arrangements and offering a framework to connect the BCE across places and with system-wide health and care work. It describes a vision of an equitable partnership embedding the BCSE at all levels of the ICS that recognises and values the sector across strategy, delivery, engagement and insight. It's about values, principles, responsibilities and system-wide enabling priorities to strengthen partnership working. And finally, it sets out an approach for embedding the BCSE within system work and the role of the developing South Yorkshire BCSE Alliance to support this. So Barnsley CVS are members of the ICB BCSE Alliance Leaders Group, alongside Von Traction Rotherham, Von Traction Sheffield and Doncaster CVS. Together we have commissioned research into what is happening in our sector, the number of organisations and basically what is being provided. That will inform an improved understanding of the current size, scope and challenges and opportunities in the sector. And that alliance works with the wider sector through a series of events. In Barnsley, what this means is our task is to ensure that these are not just words and that the VCSC are truly equal partners in what we're trying to achieve. I have said before in this meeting that Barnsley CCG did not always work well with our sector, and we need to make sure this changes with the PLACE partnership. There are over 6,000 VCSC organisations across South Yorkshire, and there are more than 1,000 in Barnsley. There are still some issues that we need to iron out. For example, the way the ICP representation was organised left us in Barnsley with no representation from our sector on there, and we have to go to other areas for that. But on the plus side, in our draft health and wellbeing plan, we've got a whole section on the partnership with the VCSC sector with deliverables and outcome measures. And within our own sector in Barnsley, we've now formed a clear structure through which we can communicate with all our diverse organisations. This is a massive opportunity for us in Barnsley. We've got the structure in terms of the memorandum of understanding of how we're going to work together. And we've also got the VCSC infrastructure organised, so we can be communicated with now. It does make me a little bit sad when I hear about services that are running where there hasn't been cross-sector discussions in terms of the provision, because what that then means is that the people that are using that service are not getting the benefit of everything that we can provide together. And I think it's inherent for all of us that we need to make sure that we're working at every level cross-sector. So it's a very positive thing, and I think we just require it to be noted.
Thanks, Jay. That's very, very clear. And I hear what you're saying about almost like living this. We've got to live this, haven't we, rather than it being words on a page, really. And that same principle applies to us in our PLACE partnership. We've got to really work hard in terms of making sure that we live that. There is just something then about that cycle of communication, isn't there, to the VCSC Alliance that we might need to think about, you know, how we do that. And I know that there was obviously, I think Joe, wasn't it, that attended the big event that you had around the VCSC. So I think that was a probably kick-off conversation in many ways. So yeah, should we give that a bit more thought? Okay. Any questions for Jane? Okay, thanks again, Jane. We do have a 5-minute break. We're desperate for a 5-minute break. Right, it's a 5-minute break. Then what time is it? If we come back at yeah. Oh dear.
He had 2 sandwiches yesterday, big donut. And what else did you have? You got a stalker, donut.
And then one of them little square chocolate.
Personal trainer.
No. He said, oh, I've got high blood pressure. I said, that's not going to do your high blood pressure any good.
Not actually people like me. Just me. Well, yeah. So, with the wonder why people. Get some more water. My mouth's getting dry.
Are you feeling better? No.
Are you not? Lot better than what I was. Yeah.
Yeah. You're all right.
Yeah, every time I try.
There's a lot of
That's it, yeah. Like everything.
That's just what people say.
Yeah.
Don't they?
No, right. You know, I never thought sick. And it was so unusual. I won't do me any harm. So yeah, it was so unusual. You know, it was wheezing. I was like, oh God.
That's mystery shopping a bit too far, isn't it? Well, good. I'm glad you're feeling better.
Yeah, I'm feeling better.
Sign you need to look.
Well, I could do. I don't know. My grandma had to be. So I think today was amazing. It was all okay until 12 o'clock. And then it just, you know.
I'm trying to think in terms of the group.
So I'll have to finish here and go pick up the page.
We've only met once, and then as a group,
Challenge to
we
like
have
switch off, switch off.
meeting, but I have had a proper meeting with
Because
Bill Danny from BHF. They were both two new members of the group. She sent her apologies to the second meeting. She couldn't make it. So I think it's just
something company, yeah.
partner as everybody else around him. Because it's quite daunting being in there with like, you know, Neil from the council. I know. So yeah, so I think it's still early days to be fair.
Yeah, we all get up for a drink.
We'll get there. It's just we're all still learning. We're all still.
Third meeting this week, big.
Oh, was it this week?
Yeah, we're just like, who do you involve? Who do you not involve? No.
Yeah, but one just. Wendy was there.
Across South York. Yeah. Yeah, brilliant.
Yeah.
Because if you don't.
Yeah. Well, and having connections is going to be very, very important to you as an organisation. And I think just know to go and speak to in that scenario. Anything from a kind of council perspective, actually what we're doing there, in that space with Neil, and having those conversations. There are ways, if you've got a well-developed relationship, it does help.
Yes. Definitely. Well, it's that trust factor, you know, that someone's revenue.
Yeah.
Missing out key data.
Yay.
Good.
Yeah. I know, to be doing something. Yeah, been this house, got it.
Richard's gone. Called you over the call. Carry on. Thank you, everybody.
Thank you for that, PSD. I can honestly feel a difference.
So, only 18 months. So, we are, yeah, he's on his call. All right, thanks for joining us. Thank you. Thank you. So, are we all back? Everybody's back, I think. Yep. Well, then Richard's taking a call. So let's go on to item 16, Jane, and welcome Joe Harrison as well.
Hello. So we've got the quality report that includes an attachment of quality metrics and information from our key providers and on all our providers really. And it draws in all the information about quality, about CQC ratings and enhanced surveillance. So this report that the team have worked really quite hard on and trying to align that to the quality group, to the ICB quality committee, to the quality committee, quality committee in place. And obviously something to share with the board here. So it still is a work in progress. So we're happy to pick up any questions about that should we need to. But there's two areas that the Quality and Safety Committee wanted to draw to the attention of the board today. And the first one is something that the board is familiar with, and that's about the eating disorders. So we brought that to the previous, not previous, but the one before, partnership board because it was brought to the Quality and Safety Committee's attention by BHNFT, who had seen an increase in the need for specialist support with regards to that and why. So the Quality and Safety Committee did have an update. So we have now got, so the membership has been reviewed. We've got 2 all-age eating disorder groups within Barnsley, so we're able to get ahead around that. We've reviewed the membership for that. The governance groups have also been reviewed to understand where the area is discussed, where it goes to, where it comes out. And we agreed with the committee that the objectives and work be reviewed in May. And so the Quality and Safety Committee wanted some assurance with regards to that. And the group that will meet is going to set up a small workshop style meeting to begin to complete a baseline exercise of what's currently provided, so that we could actually start off with, this is what we have, looking at best practice, this is what we need, and these are where our gaps are. So this, it will be brought back to our Quality and Safety Committee so that's really, really positive. I think it has moved on, even though it's just going ahead around who's meeting, who's driving it, where the government sits, and getting to the point where, you know, we've got a group now that will really look at completing the basic exercise about what we put in place. So that's a really positive way forward. I don't know if the board today wants us to keep moving this back. It's going through the Policy and Safety Committee as an update every time, so I'm not sure if we want to see that, or whether we need later on in the year further information to bring, but I'll leave that up to the board to decide.
Want to answer that question? Yeah, answer that question. Yeah, I mean, I think eating disorders and the whole sort of eating disorder pathway is under quite a lot of conversation at the moment. I know across South Yorkshire, so I picked up on the back of a concern that was raised by a member of the public. This wasn't a Barnsley individual, but it did highlight for me that point that you're making, Jane, about joined up working and capacity and resources really in that sort of space. So I'm really pleased to see this work taking on. So I think from my perspective, it'll be helpful to have an update on this in due course when the group feels that it's something that wants to do. I'm also aware that the Mental Health Learning Disability and Autism Provider Collaborative has also got a focus on, it's one of their priorities, is the, I'm sure I thought, glad I've not dreamt it, the one of their priorities, yes, so it'll probably be worthwhile with Marie Purdue in terms of the plans around all of that, so we are just connecting up. Okay, all right, any other points on that one? No, to keep going then, Jane?
Great, thank you. So the second is, and the reason, one of the big reasons I brought Jo in is obviously in this practically. So we had a new policy that's come into effect, the new CETR policy, and it sets out specific requirements for the dynamic support registers and the care, education and treatment reviews for both adults, children and young people. It's made some significant changes to the way that we do CETRs across the country, obviously, and across Barnsley, and it's giving us some significant challenges with regards to the capacity that we've got in place from a resource, from a person perspective, obviously doing the CETRs. We did have, 1 year ago, only 12 children and young people on the dynamic support register. And now there are 49, and the paper says 43, but it's gone up since the paper was written to 49.
35 as of today, so we've discharged some new referrals, had leak CTRs, so it's a really movable feast. Yeah, very, very fluid. Yeah, well, it's yeah.
Thanks for that update, Jo, that's really helpful. So it was discussed at the Quality and Safety Committee, and it was felt that this was a risk that we really couldn't mitigate against because of our language. And we did want the board to consider adding this to the place risk register. And again, it comes to our conversation we had earlier about the governance and the risk and so on. So I'd like to just hand over to Jo, if that's okay. I'll just give us a sort of a brief about what the CETR and the dynamic support register is, and then some of the risks that we've got because of the new way of working.
Sure. The CETRs and the dynamic support register are directly regarding the learning disability and autistic people within our borough, but nationally anyway, but it's specific to that cohort of people. Anyone within that cohort of people, a child or young person or adult who is at risk of a hospital admission, will go on the dynamic support register. Okay, and that's a register that ICBs are duty bound to hold and to manage. Our adults register is held, Gina Johnson manages that, our adults case manager, and our children's complex case manager manages the children's one. The management of that sits in Swift at the moment. There's been a lot of work done on it.
CETRs mean care, education and treatment reviews. For children and young people, it's care, education and treatment reviews, obviously, and that will be children, young people up to 19, some up to 25. That would depend on their needs and what's happening. And the adults register is just the care and treatment reviews. So this is anybody who is at risk of admission or who's been admitted. So there's community CTRs and inpatient CTRs for both children, young people and adults. So, and everybody who's at risk or inpatient is on the dynamic support register for both adults and then children and young people. So that's a multidisciplinary discussion when you are looking at the dynamic support register. Really, everybody who's involved, particularly CAMS, any education, SEND professionals, anyone who's another health professional or social care professional, like the person's social worker, should be involved in those discussions around the dynamic support register. It's the CTR policy that came into force on the 1st of May has made a few changes and opened the doors a little bit into who goes on the DSR, because anybody can refer themselves now and the family can refer them, which is quite a significant change. The only really thing that hasn't changed significantly is the fact that you still need consent from the person or parental consent or a best interest decision to be included on the DSR, and then to have a CETR. So where we're at the moment is that we've got quite a number of people on the DSR at the moment. We've got 35 active cases. There's a LEAP happening, which is a local area emergency protocol. It used to be called a blue light CTR, and those are called when someone could be admitted immediately. Okay. So and sometimes they'll be flagged as a red risk on the DSR, but sometimes they come in left field. Just the referral for the LEAP comes in and we might not be cited on them. We're trying to get to grips with that a little bit, but with the work we've done on the DSR in Barnsley so far, particularly with children and young people, those are more rare occurrences now, but they used to come in all over from left field, but now we're more cited through the DSR on them and we've got more grip on that. Okay. So, like I say, there's a LEAP happening this afternoon, so that young person may or may not get admitted. On the DSR at the moment, we've got 23 red cases, which means that an immediate CTR needed to be held for those, and then they need to be followed through, and periodic CETRs to follow up. We've got 8 ambers, which mean that they either need a multi-agency discussion, multidisciplinary team discussion, or a CTR, depending on how amber they are, keeping into red. We've got 2 green cases, which mean that we've got services involved and following them through. And also we've got 2 admitted. One of them has an eating disorder. One of them is got a lot of challenging behaviours. Both are on the autism spectrum. Okay. And what we've tended to see with the number of children and young people, particularly that we've got on the register, this is where we've got the most the most work to do, I think, here, is that we've got a lot of young people with ASD, ADHD diagnosis, or not diagnosed, possibly no LD diagnosis, but possible LD. So we've got some change in diagnosis as well. CAMS cannot work with all of them because they have no capacity for LD as such at the moment. Then that's not in their spec anyway. So we've got a gap, and we've got no learning disability nurses, as we know. So we've got that gap there. But the eating disorders are of particular concern. A lot of young people coming through with autism and ARFIDs, as we know, and services are stretched as it is to look after those and those young people and support them. So of the 2 admitted, they've been in quite a few months, and we've got discharge plans in place. But I think what we'd like to, the reason we'd like it on the risk registries is because of the new policy. The way we do CTRs at the moment will change. We can get away at doing them virtually. We can do LEAPs virtually. The new policy is saying you're not doing that. You're going to do it face to face. You're not going to do an abridged version of them, because we can sometimes get one done in a couple of hours or maybe half a day. What it's saying is that you must have these professionals there, and you must have them there all day, and you must go through every single care plan and every piece of paper and documentation that relates to that person's care
that's young person or adult. And what the policy also says is that if the person's got a named social worker, them and their team manager should be invited to the CTR. If not, the directors of social services should be invited. And when you see that in writing, it kind of think, well, there's going to be some impact there, isn't there, in the way that our services and our systems are so pressured at the moment. So that's why we'd like to ask for it to be included on the place risk register, please.
All right, thank you. It's a very detailed update. Thanks, Jo. I'll just open it up for any questions. I do have a reflection upon it, but
So just in relation to the risk register, Jo, it's so CETRs is already on the ICB risk register with individual place updates requested. So I think we probably just need to think about how we feed the feedback from what you've just presented into that update. So it is already in there. And it's an amber risk, so it's whether the score of the risk is reflective, I think, is probably something we need to have a look at as well, based on what you've just described.
yeah, I mean, that's helpful. There's a broader conversation about the impact assessment of the application of the policy, really, practice on resources, and actually my observation is that each of the places are doing it differently. And there has to be some sort of consistency about the approach to this, really. I thought you'd say that. Consistency about the approach to this. So I've asked Kelly Glover's doing some work on this. Jamie, she's probably going to connect in with you about other observations around that. Because I think each of the places are doing it differently. It makes it quite difficult to do some of that impact assessment, really, on resources, because we need to receive a paper about that into the ICB or the operational executive, whichever route it goes into. So there's just something about that. So yeah, we know that it's already on the risk register, but perhaps there's some more information we need to do to populate it. So Jane, so take away an action on that. And also, Jane, it's probably helpful to raise it at the chief nurses meeting anyway, generally, within the ICB. And then the third one is for Kelly Glover, who's the lead for LDA, as you know, to pick up a conversation with Jamie about that broader work.
Just highlighted us as an outlier, I think, in South Yorkshire. We have a lot more referrals and a lot more, and I don't know if that's the way we apply the DSR and the decision support tool that we use, or whether there's a wider issue. So he's looking into.
So the conversation, I think, will help with answering some of that question. Sorry, do you want to do it?
Yeah, we're looking at the risk register at MHLDA as well, and I think that is another place where we ought to have those risks highlighted. And we will be basing it on the risk register, all our strategies and action plan. The important thing is to look at the risks meetings rather than a lot of papers that come in. And I think that's an opportunity for us to intervene at that early stage rather than wait for it to come here. And then we can bring it further through the MHLDA to the DG and to the partnership.
Jane, do you want to come back on that? Let's have a reflection.
It comes back to our earlier conversation, doesn't it, about the governance, about the groups, and about, it can become quite complicated. I lost sight of that on the risk register. It is. I can remember because I was there and I to word that on the risk register. So, we'll sort.
It's just an opportunity that at that level, and then bring the governance structure that way as well.
Yeah, because it's the right risk being held at the right place, isn't it, for the right reason? Yeah. So yeah, thanks, Jo. Okay, anything else, Jane? No. Okay, thank you. Okay. Let's have a look. What more to finance? And we've got no other items for governance. Finance performance next.
Yeah. So if I'll cover agenda item, is it 17? Yeah. And then Jenna's joined us to cover agenda item 18 in terms of the place position. So in terms of the Barnsley element within the ICB, we ended the year with a surplus position of £550 million worth of expenditure against a budget of £551 million. The 1 million surplus was used to support the wider ICS, so that's the system in achieving its financial balance. So every organisation was asked to improve their position as we ended the year within the ICS, and I believe everyone or most providers did that, and the ICB also contributed to that position. In terms of where we ended the year in terms of efficiency, It's probably fair to say that the majority of our efficiency in last financial year was done through non-recurrent measures, with very little in terms of recurrent spend reductions. The one contributing factor was prescribing, which we do every year in Barnsley. But actually we under-delivered against that target as well. So we set ourselves a 3 million target and delivered 2.6 million of that 3 million. That trajectory is reduced again from prescribing for next financial year, which Jenna will come on to in a moment. But as you can see, the opportunities get smaller as the years progress when it comes to medicines, because we did start up at about 4.5 million on medicines management a couple of years ago. So the scale of the opportunity does get smaller as we progress through the years. So essentially, that's agenda item 17. Just for the place committee to note the outturn position. I'll not cover too much detail in terms of 23-24 because we're going to have a presentation on that next, and then I've got a bit of an ask of the place committee in terms of next steps against that financial position. I'll take any questions at that point.
We want to do the next item and then take any questions at the end.
Okay. So I'll introduce Jenna. So Jenna Miller works in the finance team within the ICB. She's presenting the paper that's in your packs that came out as part of the separate agenda item. She's presenting on behalf of Place. So she is representing today Swift, the hospital, the council and the ICB. Martine has rightly so reflected that we haven't captured the hospice information in here, and we will endeavour to do that as we move forward, as well as primary care. But we have only just introduced Isabel and Phil. I think it's Phil.
Yes.
Yeah. Into the group. So actually, we will expand as we kind of progress. It's still a bit of a development. So Jenna, if I hand over to you to take us through the slides.
Yeah, thank you, Roxana. So on to the second slide. So this presentation is confirming, as Roxana's just mentioned, the final Barnsley Partnership financial position for 23-24. So this slide gives a bit of an overview. So prior to any 23-24 efficiency targets, the overall partnership deficit is 73.1 million. And that's based on expenditure of 1.286 billion against income of 1.213 billion. The planned efficiency for this year across all partners in Barnsley is 39 million, and this actually reduces our 23-24 deficit position to 34.1 million. As noted in the slide, sorry Kay, just moving on to slide 2. Thank you. So as noted, the figures above on this slide at the bottom just mentioned, so this includes for BMBC, it's not their full position, it only includes health related services, but for the Swift service it does include everything at this point in time, so the full organisation position for Swift. If we just move on to the next slide. So the next 2 slides actually give a breakdown of the plan by individual organisation. So this slide at the moment shows the deficit before efficiencies, which is the 73.1 million split across organisations. It gives a breakdown of the efficiency target, so the 39 million by organisation, and then gives a residual deficit across all organisations. Again, bringing us back to the deficit of 34.1 million for this financial year. Moving on to the next slide. So again, this is the same information, but just in a bit more detail. So it's just splitting it down into kind of income, so you can see where our income actually flows through from, and actually pays non-pay or expenditure split by pay, non-pay, and then contract and services. Just to flag at this point, as you can see, there's an asterisk on the contract services and the allocation line. That's actually saying what we've actually done is net off any internal income and expenditure between organisations within Barnsley, so it's a net position that's actually being presented at the moment. The next slide gives a list of the key risks that we've got in the system at the moment, covering workforce and staffing, prescribing and drugs, continuing healthcare and social care, complex cases, and then the achievement of actually the recurrent efficiency target of the 73.1 million, which I've mentioned earlier. And again, we've just referenced in this slide, of which 39 million is actually required to achieve the 23-24 plan. the plan that's been agreed at the moment. If we move on to the next slide, please, Kay. So these next two slides just give a breakdown of the efficiency target that we've got by each organisation. So this is the 39 million that was referenced earlier. As we can see, for South Yorkshire ICB Barnsley, we've got a target of 10 million. Swift is nearly 12 million. Barnsley Hospital 12.5 million, and BNBC is 5 million. What we've got in this slide is showing actually at the moment, so it gives a bit of a kind of risk status as we are at the moment. So we've got what's already identified in organisations, what's currently work in progress. So again, it's a bit more riskier because it's not been completely finalised as yet. And then a level of unidentified, which is obviously more risky at the moment. These will all be monitored in year, and that's our key focus for reporting going forward is the risks and efficiency programme. On the next slide, this just gives a bit more detail again from the efficiencies. So actually this is a breakdown of kind of the themes or service elements that we're looking at from an efficiency programme. Just to flag in this area, there is a typo. So BNBC's total is missing, and also that total's not added into the total. So the 34508 is actually the 39 million. So there's something missing there, which I'll actually pick up and amend that figure. So apologies for that. What we're doing at the moment is, again, these are kind of the top level. We're working in the finance group and including efficiency reps across the partners, just to kind of break these bits down further, so we can be really clear on where the efficiencies are actually in each organisation, ensuring that there's no duplication there as well. If we just move on to the next slide, Kate. So this slide gives kind of next steps for our finance group. We're proposing the first partnership reporting period for 23-24 is Q1, and we're actually just looking at the formatting and kind of ensuring that's bringing out, again, the main focus on efficiency and risk and how we demonstrate where we are in as across Barnsley as a partnership. We've got work at the moment looking at breaking down the Swift financial position. So as I raised earlier, at the moment, the whole organisation for Swift's financial position is included. We're actually looking to split that down into Barnsley and non-Barnsley. So again, in future, we're looking at it would just be Barnsley that would be included in these figures. We've talked about Q2, the end of Q2 being the timescale for that. And again, we've talked, again, working with Swift, we'd be really clear on transparency for that methodology that's used as well. So all partners are kind of aware of the process that we've gone through. One of the kind of, again, linked to the focus from efficiency and risk, there's going to be a collective review of potential further opportunities for efficiency, and this is linked to activity finance and interdependencies across partners. So the finance reporting group is actually being expanded to include performance, business intelligence and efficiency reps from all partners, and again taking on into account what Roxanne has just mentioned about linking with the hospice and also primary care as well. So we need to expand that group and the terms of reference there. And the last one at the moment that we've got is considering options for the medium and long-term financial plan as well. So this is about achieving financial sustainability, which I think probably links in with where Roxana's going to step in at this point.
Thanks, Jenna. That's very helpful. Yeah, thank you. Thanks, Jenna. And it's worth noting that, so just from a primary care and a hospice perspective, so the contributions from the ICB are included within the ICB element of expenditure. So on that service and contract lines includes all our primary care expenditure and our contribution to the hospice at this point. But in future, we'll try and draw that out through presentation. So if you can, already done it. Thank you very much. So in terms of where that takes us then, in terms of next steps. So we've got the finance group established. We've got some fairly robust process and systems in place to try and identify where we've got to. But actually, we felt that to do this properly and maybe differently to how we've approached things in the past, we probably needed to take a different tactic. So So the next steps for the partnership board are that, so we've had the place plan presented to us here today. What we've started to do is enumerate that plan. What that has initially identified is that there are probably just a small number of areas which will deliver financial contribution across the system. And therefore, given the level of the significant financial challenge, we probably need to be more ambitious in terms of what work we want to take forward. That's not to say that anything in the place plan won't be progressed, because it will, but there may be a need for us to refocus our efforts and resource into the areas of biggest opportunity, which is back to the session on the 13th of June. So we're going to look at the scale of the opportunities using all the tools that are available to us through a finance and data and intelligence lens. That'll just tell us where to look, not necessarily how big of an opportunity it will be, or whether we're even going to get anywhere near the level of efficiency that is suggested. But actually, it'll give us a good starting point in terms of where we ought to start. In terms of the next slide, then, so it's proposed, and I'm looking for support from the board today, that we focus the session on the 13th of June on kind of where are our biggest opportunities. So we're asking that each partner considers where we could jointly develop areas that will reduce cost, improve patient experience and quality in care, and maximise system capacity and resource. So that's working together, and how do we do that with the collective resource and capacity we've got across the system? That we confirm we're in agreement that we want to work together to drive financial sustainability across organisation, recognising that there will be some organisational risk in that, and how we will agree how we want to manage that across the system. There'll be some double running costs. But actually just remembering in terms of the kind of our why in Barnsley, and actually it's the people that we serve, and actually how do we use the resource capacity to the best of its ability. So I'm recognising the value in each other, in terms of actually we've all got to sit down, have the conversation and do it together, because some of the things that we want to do will no doubt have an impact on another part of the system. And I'm just very conscious that actually from the conversation with Jane today around voluntary sector, and how do we bring them into that conversation on the 13th as well, and just make sure it is very inclusive. And then that we just consider our approach to take forward plans through collective ownership that deliver cost improvement and cost reduction, given the fact that we know we've got significant financial challenge ahead of us. We know we're going to be asked to go further in terms of our plans. So we've submitted plans, but we're going to be asked to go further, and what are we doing against those plans? And we just need to be prepared in terms of that recurrent underlying position that we all know exists across Barnsley, and how are we going to deliver against that in 24-25. So this is not quick wins. There may be some quick wins in what we agree to do, but actually what are the things that will sustain the services that we've got in Barnsley? The plan then would be to bring any outputs from the session on the 13th then into the July partnership board. So that's on the next slide. With an approach and an agreement that collectively we will strive to deliver that together. So that's the ask of the partnership board today, recognising that this can't be done with the accountant sat in the room. This is just we are providing you with the position. We will provide as a collective group where to look, what the opportunities are, but you will all know where those opportunities are, and where within your own organisations that actually if we worked much better together, we could be much more efficient in how we deliver care.
Thank you again, Jenna, and thanks Roxana, and all of our CFOs actually for putting some work into this. Really, I think that the value of that finance group, I think, is coming into its own, and bringing performance, I guess, into that as really as a sort of a community and a improvement, really, in some ways. But let's open up for any questions that anybody's got. I mean, there's a clear proposition there that we need to reflect upon and support or challenge. That's the nature of the conversation today. Bob's kicking us off.
It's just a comment and reflection, really. Just want to support what Roxanne is saying. I think that, yeah, we can do the analysis, but we really need ownership across the board in terms of identifying areas, seeing it through, assuring ourselves from a quality financial point of view. It won't be 2 or 3 things. It'll be a whole set of schemes. That's the way these things work. I mean, just today, we send out 700,000 letters a year as an organisation. I don't know what that number is for the place, but obviously that would be a good thing to look at, seeing as though you can get pretty much everything on your phone on the NHS app. But we need to think about digital inclusion and engagement, because we won't stop all letters. We've heard about how it is for homeless people and the efficiencies and the poor outcomes for them. You know, there'll be a lot of opportunities, and we think we need to just get in the mindset of what we can do, what we can't do, and that needs everyone to embrace it, because that's the most responsible thing to do, really, and think about, you know, well, if not now, when, and, you know, a 3-year sort of approach, really.
That's a helpful reflection. I mean, it's helpful to hear from. I'm going to ask everybody to give a view. Actually, I think it's really important. So, Jill, from your perspective.
Yeah, I mean, obviously, we're committed, aren't we, to making sure that we do the right thing for our population. And actually, if we don't work together, we'll just increase the health inequalities that we've got out there, which will actually drive more use of services. So I think we do have to get on the front foot and actually really ask ourselves some of the tough questions around actually what can we do better together that will drive out some of the efficiencies.
Yeah. And ideally improve outcomes from which financial benefits are banked. I think that's our sort of narrative, isn't it, really, I think, around all this. Salma, did you want to add anything from Swiss perspective?
No, I think just to reiterate what you said, it definitely feels this time round that we've got, that group's definitely got some momentum, and I think will hopefully enable us to make the right decisions across the system, I think. So I think a huge thank you to the team, because it's not easy work, is it? But it's helpful.
Yeah, they have galvanised as a community. The hospital, we've heard from Bob, Richard.
Yeah, it's not really an ask, is it? We've got to do this.
Well.
Very hard. I don't think I understand how we're going to get there. So it's one thing to say, yeah, we'll all do it together, but working out the mechanisms and using it to a bunch of transactions, we can actually deliver this much more difficult.
Yeah.
I think identifying where we're inefficient is important, where we've got the variable pay. I think remembering that integration. We've got a separate hospital and community provider. That means we need to work really extra hard on creating pathways and getting leadership involved to get people into the community. So those are some of the things in my mind.
Kevin, you don't want to?
No, I wouldn't add anything much. I'd agree with Bob. I think you just got to be careful about unintended consequences with when the public feel, and actually we need to find a way of taking the public with us in a way that in my 40 years in the NHS we've never achieved in the past. So there's some real challenge there, but we do need to take the public with us if we're going to deliver on this. They've got to be a complete partner in that, and it is about challenging some of the things we've done, but making sure we don't have unintended consequences that cause harm.
Yeah, that's right. Or duplication.
Yeah.
Where a singular organisation thinks this is a place where we can go, and over here we're talking about more connected system way of working. So we've got to work that.
That be joined up, hasn't it? Yeah. Actually, because that's the issue. We all looked at it through our own organisational lens whenever we're changing anything, and sometimes we will consider partners, sometimes we will not, and there will be an unintended consequence of that work that we do internally. So I think it's really important that that's why it needs to be owned collectively. My view would be we start with something we think we can deliver on, as opposed to thinking big and not delivering anything.
Build confidence, can't we? I think it's when we do things like that. But it's exactly. I completely agree.
And yet, by the time we get to that meeting, third of the year will have gone. And little things aren't going to hit this for us. So I get the point. start small, but we haven't got 3 years to do this, and we need to identify.
Yeah, no, we just need a success. I think it's the joy, the kind of the energy that comes from having a successful thing and doing something successfully together. I think that will hopefully drive then behaviours and how we do things around here, which will help us in terms of that kind of the organisational development we all need. You know, we're all changing in how we're working, aren't we? We're all thinking differently. So
But yeah, yes, you're right. There is a challenge, but you know, equally we're going to put the challenge. So we're together in extended PPDG session on the 13th of June. We've got CFOs joining us. We've got obviously many of the execs around the table here to you know, basically nail it down. James, did you want to give a view from primary care?
Yeah, I mean, you know, as Richard said, it's something we've got to do, but actually it should be something that we want to do. It's public money at the end of the day, so should we look at how we utilise that to the best value that we've got, and that's what normal businesses do on a day-to-day basis. They look at what's driving up costs and look at how they can do things differently. So we should take the opportunity to do things better.
Yeah, and let's be bold, I suppose, really, where it makes sense to be bold. You know, I think there some things I ask myself in terms of the services I'm responsible for in the council. Do we need to do it? Do we need to do it in the way that we currently do it? Who else could do it as a different way of joining up things? Even the work we've been doing, Jill, around the out of hours model. Like, why have we got a silo there and a block there and a block there? Really? Let's try and put our heads together and think differently about the opportunity. Really, because that's what it's about opportunity.
It is a brilliant opportunity to work together in partnership and to deliver services that are going to benefit people. They're not interested in how we do it. They just want to see it happening and making a difference, you know, and making a difference to their health ultimately and social. We've been talking about culture and heritage and employment and housing. It all has an impact. So as a local authority with all those different directorates, we've got to make efficiency savings. But there's lots of things going on. There's the savings going on, but the partnership working to invest in and make a difference. And that time and effort, well, you know, we may be saving and making a difference. So it's a really exciting time.
It is. Yeah. It is. Marty?
Yes, so absolutely agree with everything you said at the beginning about working together. Jane and I had a great conversation earlier in the year from BCS, and we're looking at cost sharing opportunities because you heard Jane say there's 1,000 organisations in Barnsley, independent charities, and how can we work together to reduce the cost for each independent charity? And we're also looking across South Yorkshire to have a South Yorkshire CEOs for hospices, again, to see how we can create some cost sharing opportunities. So we're doing what we can to lower our costs.
Great to hear all that. Madeleine, what to add anything?
Not more than what everybody else said. I think there's no choice. You just have to do it and do it collectively and just look at how we can work together to maybe reduce the costs and maintain the care.
I think we have given collective leadership to this challenge, I think, really, and it's beholden upon us all to get on with it with and alongside the public. So the point that Kevin's made is really important, really, about how we do that together in a way that's meaningful and purposeful. So more to do. We'll bring a report back, as we said, in terms of our progress. And yeah, unless there's any other questions. Oh, happy to move.
Thanks, Jenna.
Move on. Thanks, Jenna.
Thank you.
So we have got then at 19 a number of reports for information and assurance. So we've got some get back to the papers, that'd probably be helpful, wouldn't it? The list of decisions that the senior management team have made recently for transparency. Are there any comments on those at all? My children are having a great time outside.
Others helping them get across the road.
Actually, a bit of a side issue, but I was chasing when the roadworks were going to be finished outside actually earlier on today. So let's take 19.1 down to 19.5 and ask us if there are any questions at all from that block of information that you've got there. No? Side of the table, anybody on Teams? Any questions? No, to the left of me, any questions? No, okay, that's great. Let's record those as noted. On to item 20, updates and any escalations from partners at all? Anything?
Or just general
sorry, Bob.
before, is it? I had a few things. Just, I mean, I think just urgent care in general across the place is, I think there are significant pressures, but it's holding up well. You know, like things are working, a lot of things are coming together. Got a lot more to do. We need to follow up on that ESA stuff, but Maddie, you were talking about your practice took it nearly
782 calls on Monday.
on Monday.
How many, sorry?
782.
Maddie was saying she
Just
took
more
them all.
practice then.
370 attendances at ED on Monday, but we're recovering. We've got all that support in place as a system, so it does feel quite hard. We're progressing with the putting not rather than escalation beds in place, and we've just had a nod from the ICB for £2.5 million for the estate to support that work, not revenue. But it should be a more cost efficient way of dealing with the flow. One bit of bad news: junior doctors strike confirmed 14th to 17th of June, 72 hours full walkout. So that will slow down recovery. We'll focus on urgent care. Tricky. I mean, it was last time was a tricky time of the year, but well, unfortunately, or fortunately, we've learned how to cope with it a lot better and do that. And then just ending on a positive, just the award, the Royal College of Midwives award we got for the joint work we do around perinatal mental health. Yaz was the face of that, one of our midwives, but a really good recognition around that. I think she was pulled by one of the panel, just saying absolutely really good piece of partnership work and a really good offer to women in Barnsley, so increasingly outside of Barnsley as well, but so real positive there.
So yeah, so that's really good news, and credit to the individuals working in that space. Matty?
Yeah, just two things to make sure everyone's aware of. Proud of Barnsley Awards. Is it all on your radars? Because it happens on November the 17th. And apparently it's a very glittery event for Barnsley. I only found out about it earlier this week, so I'm just sharing that. It's run through Barnsley Chronicle, so all the criteria and everything, and I just thought there'd be plenty of people who have staff from around this table who might
know what to nominate.
Yeah. And then the second thing, what's everyone doing on Monday? Barnsley.
I'm more interested in what's happening in the Sheffield Wednesday versus Barnsley match.
At Wembley.
Monday, yeah.
We tuned into Saturday. Oh gosh, I thought it was Saturday. 3 p.m. I'm not going to do a hands up who's who's on that side. It's going to be a tough one, isn't it?
Well, it better be everybody in Barnsley around this time.
Well, my family is a real mix between Manchester United, Sheffield Wednesday, Middlesbrough, that's me, and all sorts of others. So it's any matches.
I have flagged Kirsty about the serious bit of it. Yeah, a lot of people will be going to Wembley, but a lot of people will be in Barnsley.
That's a very good point, actually.
In the town centre, yeah.
Thanks for flagging that, because we said we needed to pick up some messaging around that.
Yeah.
No, they have in Sheffield because I went.
No, they have in Barnsley as well.
And Sheffield's got a fan zone, so that.
Yeah, well, yeah. So yeah,
It's really hot.
yeah, there are lots of people in the town. So, anything else? Thanks, Martine. Anything for primary care? We've got carers.
Yes.
Event. I'm hoping somebody's joined the Radio Sheffield interview today about that. Given Andrew's off on a holiday, so
Yeah, I've not.
Yeah.
But yeah, that's coming up. That should be really good. There's lots of people going, so hopefully there'll be a lot of care with them.
That's building on the work of Trevor Clower, who's done some great work in this space, hasn't he, about carers roadshows. So really connecting primary care into that. So that's really looking forward to that.
9th of June.
Thank you, thank you, it's 9th of June, thank you. Anybody else? In terms of escalations, or updates really? We've talked a number actually different elements about risk actually. We just need to consolidate the approach to risk, don't we, generally, I think, and be clear about what the risks that we are holding, in what place, whether that be a partnership, you know, organisations or for the Barnsley system. So then finally, it's a reflection of how well we thought the meeting's gone. And everybody always sits really silently. Yeah.
I think the opener reflection around just brings it back for me around why we're all here.
That's it, yeah, patients.
Around the residents of Barnsley. So that was excellent that today. And real food for thought in terms of what can we do better.
Yeah, it's a glue that binds us, isn't it, fundamentally, isn't it, as people of Barnsley? Any other reflections, Marty?
I was just a bit surprised and wondering what our colleagues in the community section earlier meant when they said they thought the meeting had been disrespectful to their questions. I'm a bit confused about that, to be honest, and I wondered, did I have a micro sleep? Did I miss something last meeting?
I just think it's about the fact that we're just trying to get into a little bit of a rhythm. I mean, I apologise. I wouldn't want anybody to think of being disrespectful. I don't see myself as a disrespectful individual, if I'm really honest. But nevertheless, it's how people perceive things, isn't it, fundamentally? So
if we're not aware of what it is, then we're not going to be able to change, are we? So I just think it's important we understand what it is that they saw or heard that made them feel that way, because I can't see it.
Well, I'm more than happy to have a follow-up
It was the
conversation.
positioning, their positioning within potential for a seat round the table. That was their issue, that they wanted to have further engagement and actually be part of the structure, which is happening a little bit at ICS level. And they're looking at redeveloping the citizens' charter.
Just want to make it right for the people of Barnsley.
Yes,
I'm really pleased that people have come to the partnership meeting actually, and then
they were very positive today, actually, to be quite honest. It's very difficult answering 14 questions.
Yeah. Well, I hope I selected some of the right ones.
Absolutely spot on.
Yeah. Okay. So all we can say, more to do. We know that there's more to do in that space, and we know that. Sorry, Thelma. Sorry.
That's all right. I suppose the reflection really is the papers are really helpful because they were clear and not overly lengthy. I mean, the ones that had to be long were long, but really clear, I think. And I think that enables a good conversation and a chunk of time at that beginning bit, which is about what's happening in the real world and how we might make a difference. But it definitely felt most of the conversation was focused around the whole system approach, solutions rather than from our individual perspectives. And I think that that's the added value of this partnership board. And it really felt like that kind of was at front and centre of everything we talked about today. And again, just to reiterate, I think the challenge ahead is going to be significant for everybody, isn't it? It doesn't matter which place you're in. But I think that this group, it feels like we've got the right relationships to test that significantly over this next year and probably pick one or two things and do it at pace together. So I thought it was a really positive meeting.
Thank you. I mean, just reflecting upon reflecting on what Sam has just said then, one of the things we didn't talk about when we were talking about, you know, the plan and the need for us to galvanise around a number of things was about support in that space, because clearly the ICB is going through a change piece, really. There may be some fluctuation and some challenges with that as people are settling into new roles. It's not going to be easy, is it? Never is easy for anybody, isn't it, that's going through those processes. So we need to keep momentum and pace and ask ourselves, which is another question on the 13th. It's going to be a busy day on the 13th, about what else, what support do we need in that space to do exactly what Salma said, which is about get some pace and get some movement in there. All right, thank you, Kirsty.
Yeah, just picking up on Jill's comments about the session that Michelle took us through. I think at a previous meeting I'd mentioned, so we go out and source the stories from the communities. Normally somebody will give me an idea, which is always very helpful. But I think it might be worth us thinking about each one of our organisations or from different parts of our organisations, thinking actually this is something that we'd like to bring and sort of almost sponsoring it and bringing that in. And I think the links between the previous ones that we've had haven't been about this is somebody that is accessing a service and that's their experience. It's about some of those more vulnerable groups. It's been about health inequalities really explicitly, whether or not we sort of recognise that. So it might be that we want to keep that theme where we can all contribute to. But actually, if there are people that are thinking, actually, I really want to focus on, I don't know, whatever topic it might be, then you know, we'll help facilitate that. But I think that might be something as well that we can all then feel, you know, as if we've got more of a contribution, I think, to that topic.
Yeah, that's really helpful. So without any other, Bob, go on.
Yeah, it was just a quick one. I agree about the comments about clarity. I feel like we're being clearer. I know we talked about risk quite a few times today. I understand there's a process around the risk register. I don't want to get too distracted about that, really. I'd feel more comfortable. We could get in a position where we could sit here and say, well, these are our top 5 risks as a system. You know what I mean? Regardless of whatever the process of the risk register and all the rest of it is just, it just feels like, I don't know, just talking with the colleagues and stuff like that is being honest, and this is what we're doing about it, actually, because it consumes so much noise and energy. The anxiety around it all, is it, you know, eating disorders, just as one example, really clear. This is what we're doing. When you want us to come back, when you've got, you know, we can see what's going on with it. We've taken something that's quite difficult. We're processing it. We're playing it back in. It's, you know, I think that would be good. But definitely, I agree with the comments. It's good. We're getting there.
We'd all agree with that view, Bob. It's almost less is more, isn't it, really? And that we've got some real grip of those, and we can feel collectively assured that we're making some progress in tackling some of those areas. So the final reflections is we talked about the development session. We've got some themes for that, particularly the hospice, update in terms of how we're going to organise ourselves for the plan, etc. That'll be the main themes for the development session. The session on the 27th of July, I'm just conscious that we have all these meetings in Hilda House, and we do, and I know this convenient in terms of people joining by teams, and we do have some limitations around community venues that are hybrid, have got a hybrid facility. I mean, we could, the hospice.
You're very welcome. Please come.
Yeah.
I'd love you to all come. That'd be fabulous.
So do you feel, so you could host the meeting on the 27th? That'd be really helpful if we should do that.
About town hall, wasn't it? In town hall?
We were exploring the town hall, and apparently there's some issues, there's some challenges, isn't there, Kay? But we need to catch up with the IT about the hybrid functionality. But we do want to take this the road, really, to be honest. Don't need to be hidden in here. We're not hidden up because it's recorded, but in here. So we do need to do more work on that space. Well, let's work on the hospice for the July one. Okay, thanks for joining. Enjoy the weather. What's left of it today? We get some rain.
Some of us hanging about.
Sorry.